Okay, well, welcome everyone. We're very pleased to have you with us today. For those of you who are joining us for the first time, this is our third meeting as a part of a broader meeting series that's focused on telehealth and virtual care. We will be going through the meeting agenda in just a moment. I will just provide a little bit of brief background as well.
Shut the door on my face, so I have not even been able to.
Looks like we need to make sure everyone's on mute. Great. Okay. And so we did have an introductory meeting back in December. For those of you who were able to join that, that really elevated a lot of the key themes that have been woven throughout our meeting series. And then we recently held a meeting that was focused on improving access. And as I mentioned, this is the third meeting that's focused on care delivery and innovation. And we do have a website that has meeting materials available for the previous meetings as well for your reference. If we can go ahead and move to the next slide, we can go ahead and jump into the agenda. My name is Aisha Salman. I'm the director of our Action Collaborative on Countering the U.S. Opioid Epidemic. If I didn't say that already, as I mentioned, this meeting today is focused on improving care delivery and innovation within telehealth and virtual care as we look at pain management as well as substance use disorders. So you can see the program laid out here today. We'll start fairly broad, and we'll make sure that we are kind of starting off with a shared set of understanding and definitions around what we are looking at when we're discussing virtual modalities. We'll move into discussions about the care team. We'll also look at different care settings and different types of clinicians. And then we'll move into looking at this from a systems perspective. So hopefully this should provide a fairly comprehensive picture and really be a forum for meaningful discussion. I will note that this meeting is meant to be discussion heavy. We do want to be able to explore what hybrid care really looks like and really do some of this thinking and reimagining even with you all today. So that's the agenda. We do have a couple of breaks that are built in as well, and we'll aim to wrap up around 5 p.m. Eastern. We can move to the next slide. I think we have just a few quick logistics and ground rules. I think all of us have been doing this enough to where I don't need to go through all of these bullets. What I will say or underscore again, I guess, is that this is meant to be interactive and really focused on discussion. So please do contribute, whether you want to raise your hand and contribute that way, or you can use the chat function as well. The chat is a great way to be able to contribute as well. And then again, please do make sure that you are muted throughout this meeting, especially if you're not speaking. And we look forward to the program today. So with that, let's go ahead and move to the next slide. I think we'll just briefly, yes, we do have our planning group members here. So just a thank you to them for all of their hard work and really thinking about how to best structure this agenda, who to bring to this meeting today, and how to explore this in a really thoughtful way with all of you. And this initiative is co-chaired by Helen Burston of the Council of Medical Specialty Societies and Kelly Clark of Addiction Crisis Solutions. So thank you for your leadership. I'll turn it over to the two of you next to provide some quick opening remarks and also walk us through the objectives for today's meeting. Thanks.
I'm happy to start if you'd like, Kelly. So just briefly, thank you for joining us today. Thanks to all of our speakers for putting together their presentations. We're really excited to hear this. Just to say that this session has very much been building organically over time from our opening session on what could be virtual care opportunities in both chronic pain as well as SUD and OUD. And I think what became really obvious through the first conversation, certainly the second one, and I think really highlighted today, is less of a conversation really about whether it's virtual care or in-person care, but can we co-create with patients and clinicians, payers, purchasers, and others what's a new model of care for both SUD and pain management that really kind of brings the best forward so the right patient gets the right care in the right time and the right setting, depending on what they need. So really this very holistic view of what that care could look like. And I think you'll see as we walk through the agenda and what we're talking about today, we're trying to get a really wide range of perspectives, but very much a sense that we can't do this without co-creating with patients and their families, in addition to those who take care of patients. So with that, let me turn it over to Kelly, who will introduce the session and our objectives. Thanks.
Great, thanks, Helen. And thanks to all of you for being here. We have got a lot to get through today, and I want to remind folks who've been on these before, or tell those who are new to this, that this is being recorded and will be made available on the website, as well as the proceedings of this will be put together in a written form later. So what we are trying to do is to get as much information, both depth and breadth, as possible captured during this meeting sessions. And we're trying to get it from as wide a variety of stakeholder groups as possible, with tax-paying organizations and nonprofits, with small and large companies, with government and academia, and startups and Fortune 10 companies, and a whole range of folks. So representing multiple backgrounds. So everyone who's on this call, you have the opportunity to give that information to us to capture as well. So please use the chat function that's going to be captured, and put out those questions, because it's just really important that we get the kind of information that we're trying to get to help move this field forward. So across the meeting, what we're looking for is we're looking to consider how delivery of pain medication and opiate use disorder, and in fact all of substance use disorder, which I'll call SUD, can be reimagined in that hybrid environment. And the applications of those virtual modalities. What are the virtual modalities that are available? How can they be applied? And then sort of where there are risks and benefits, pluses and minuses. And then what are the opportunities to get into that hybrid team, as Helen was saying. I know I'm saying this too much, but we can't say it too much to tee up what we're really getting at here today. So in the first session, we're going to focus on how to redesign care pathways using these virtual modalities. And I'm going to tell you what we're going to focus on first. We're going to be focusing on how we can really deliver what are these modalities, what are the barriers to accessing the modalities, and then the barriers to scaling these modalities, with the thought of determining and discussing ways to get around these barriers, over these barriers, manage through these barriers. And so the people you're going to be hearing from are a very eclectic group today, with a lot of experience to share. So first, we're going to get a high-level overview of the introduction of what these digitally enabled care delivery modalities are like, from Dr. Lewis, or Lou Levy, who is the Chief Medical Officer of Public Policy and Strategic Partnership at Teladoc Health, where he provides policymakers and key stakeholders with clinical insights and education on the role of virtual care and digital health technologies, as well as payment reform and virtual and regulatory reform. He also lends his expertise as a member of this NAM Opioid Action Collaborative Pain Management and Evidence Standards Working Group. After Lou, we're going to hear from Dr. Leonardo Angeloudi. He's a deputy director at the National Institute of Drug Abuse, which I'll call NIDA, in the Office of Translational Initiatives and Program Innovations. He advances research translation there and utilization of innovative programs to accelerate application of research discoveries into the prevention, monitoring, diagnosis, and treatment of substance use disorders. And we'll be interested in hearing from him. I think NIDA and National Cancer Institute are the only organizations in HHS that have that mandate to translation. Then we'll be hearing from Dr. Karen McConnell. She's the Chief Pharmacy Officer at Common Spirit, which is one of the largest nonprofit health systems in the US. She oversees the entire pharmacy enterprise, inpatient, ambulatory operations, clinical, retail, totality, including Telepharmacy for their 142 hospital system in 21 states. Then we'll hear from Dr. Amar Sethi. He is a physician, he's an anesthesiologist and CEO. of Patient Premier and co-creator of the Pain Scored application. That's a mobile app platform for pain management that provides remote patient monitoring and chronic care management services. And then we'll hear from Dr. David Gasfriend, an addiction psychiatrist and co-founder of Dynamic Care, which is developing prescription digital therapeutics for substance use disorders. So we have quite the panel today. We are going to, again, kick off with Dr. Levy giving us the overview. And then I'm going to ask each of our panelists to talk for 3 minutes about their space, not just their organization, but their space. And then we'll get into what's a pretty substantial amount of time for Q&A and discussion, which I'm very much looking forward to. So, Dr. Levy, the floor is yours.
Thank you so much, Kelly. If I could have the first slide. So I'd like to talk broadly about digital enabled care, kind of define a little bit of what this space is all about. I should mention that Teladoc, we're a publicly traded company serving over 70 million individuals around the world. We do not currently today have a specific substance use disorder program or chronic pain management program. But as we talk through some of our own capabilities, as well as the overview of digital enabled care, I think we'll be able to weave in an understanding that so many of these tools really are useful, as Helen mentioned, as part of an overall hybrid approach towards treating these disorders in a new framework. If I could have the next slide. So we know that currently conventional brick and mortar solutions are falling way short of the goal of treating every individual with a substance use disorder or a chronic pain disorder. We know that approximately 21 million Americans are suffering from these disorders, yet only about 19% of these Americans are getting comprehensive SUD treatment. And the condition is even worse in terms of disparities in healthcare delivery. About 10% of African Americans are receiving appropriate SUD treatment. Prior to my getting into digital health, I was a full-time primary care physician at the Brigham and Women's Hospital and Harvard Community Health Plan, which later became Harvard Vanguard Medical Associates. Most of my patient practice was really serving inner city Boston, Dorchester, Roxbury, Mattapan. And the disparities in terms of healthcare delivery were something that I could clearly see on a day-to-day basis in terms of my own practice. So clearly we need to do better in terms of serving all populations. Next slide, please. So what are some of these modalities? So often when people are thinking about telehealth, telemedicine, virtual care, they're thinking about video visits. And I guess one of the important points of this talk is to really broaden that understanding out, that when we're talking about these types of solutions, we're talking, yes, about video visits, but we're also talking about a number of other modalities. Digital diagnostics. This is broadly defined as algorithm-enabled diagnostic support. And this is an area where one can use digital tools that can help both patients as well as providers arrive at much more accurate diagnoses going further. One of the areas in terms of individuals, and actually, interestingly, we just heard a talk from Dr. Mark Graber, who is the founder of the Society to Improve Diagnosis in Medicine. He gave a talk to Teladoc Health actually just right before this talk, and he talks about premature closure. He talks about the fact that clinicians will often move very quickly and use category 1 thinking and quickly arrive at a diagnosis. And yet these digital tools can help broaden that diagnosis so that clinicians are having a broad differential when approaching individuals with substance use disorders, as well as chronic pain. Digital therapeutics uses evidence-based techniques such as CBT and really gives that kind of complete and comprehensive feedback to the individual so that they can get themselves better. And often these tools can often be very cleverly integrated in terms of the overall care team. So the individual may have access to certain tools, which in and of themselves can help the individual, but then they can also get integrated into the care team itself. RPM, we clearly have a lot of experience in this domain with the merger between Teladoc Health and Livongo. We have a number of individuals who have digitally enabled care for a whole host of medical disorders, starting out with diabetes, but now extending into hypertension, prediabetes, congestive heart failure, chronic renal failure. All of these devices are enabling individuals to lead healthier lives through getting direct feedback in terms of how they are doing. E-consultations are incredibly important. That ability for clinician to really reach out, get the expertise of individuals such as Kelly Clark when they're confronted with an individual with a very complicated substance use disorder, so that best practices can happen and that one can get access to this top level type of expertise. And telepharmacy, we'll be hearing more about that from Karen, but it really does involve telecommunication to really enable individuals to use pharmacotherapy to its fullest advantage. Next slide, please. When we talk about digital treatments, we're really talking about using software and data science to treat a whole host of diseases. And these are behavioral interventions that are standardized, they're scalable, they're cost effective, and they really do have the potential to augment much of what we're doing in substance use disorders, as well as in chronic pain. These are not the general wellness apps that one might find on sort of the Apple or Google store. These really are medically grade digital technologies that are really designed and tested to really provide superior outcomes going forward. And much of that testing is definitely a work in progress, but incredibly important. Next slide, please. And we believe very strongly, as Kelly said, that it is important that all of these tools are used in coordination with the overall healthcare delivery that each and every individual is receiving. Higher coordination of care, better integration of mental health. These tools provide greater accessibility with less stigma. They drive better outcomes in many cases. They can reduce disparities in healthcare delivery. Much is said about sort of the digital divide, but many of these tools can be used for large segments. So while it may not be a perfect solution, it absolutely is a solution for many individuals who are suffering from these disorders. Next slide. And I'd just like to wrap up a little bit with, how we are absolutely thinking about substance use disorders. We have, as folks know, recently launched a virtual primary care program, which is nationwide. It's been highly successful and extremely popular. We do have individuals with substance use disorders as well as chronic pain in this program. And we believe very strongly that through digital enablement, one can weave together the treatment for substance use disorder and chronic pain with overall chronic care management. Often these individuals do not have a singular diagnosis. They have multiple diagnoses, all of which contribute in some way, shape, or form to the difficulties that they are having with their chronic pain as well as substance use disorder. We believe that thoughtfully integrating chronic care with urgent care, mental health, expert medical services, preventive care, and having that continuous care coordination, as well as a clear interface with the brick and mortar world, we can deliver superior outcomes through this hybrid approach.
Thank you, Lou.
Yeah, thank you so much, Kelly.
Thanks.
And I just wanted to conclude by saying that while COVID has clearly accelerated our understanding of the capabilities of digital care, I believe that we are just scratching the surface in terms of connecting digital care with all of the care that is currently being rendered for these populations. Thanks so much for this opportunity and look forward to the panel discussion.
Right. I should mention that, as you noticed, Lou gave that overview on the space, and then he talked a bit about his particular company and his particular role as he's going to join the panel. So you've got some understanding of where he's coming from in this, as well as having laid out the larger picture. So hence the more than 7 minutes. But moving on, now we're going to hear from our panelists. And again, everyone's got 3 minutes to sort of give their overview of their space and what they're doing. So we'll move on to hear from NIDA and Dr. Angeloudi.
Thank you, Kelly. Represent NIDA, the Office of Translational Initiative and Program Innovation within the Institute. As mentioned before, certainly we work in translation. That means not only the mission of advancing the science and the consequences of drug abuse, but also to apply that knowledge to improve individual and public health. We work with patients in mind. Whatever we develop, want to make sure that this is accessible by the patients. Next slide. What we have witnessing over the past years is certainly the positive that translating basic discovery and adoption of new technology in the SUD field is changing. We see our companies, NIDA-funded companies, that are successfully be able to raise interest and funding. Here's a snapshot of some of them, including some in the digital health and telehealth space. So certainly there is a positive. A lot of work still needs to be done, and agree with Dr. Levi, as also mentioned in the article that was published just a few days ago in the Harvard Business Review. The telehealth era is just at the beginning. Next slide, please. And there is certainly a need of a comprehensive approach to ensure patients access to novel, safe, and effective technologies. Within our office, we do that by focusing on several areas which fall under our responsibility. And those include building new educational programs to build a community of translational research with respect to SUD space. Taking advantage of novel funding authorities like a startup challenge, which we lead, which helps individual to develop novel ideas and minimal viable products that may or may fully develop into a product. We do oversee the small business programs for NIDA, and several of the companies they're funded, and some of them mentioned before, as well as we certainly work in developing strategic alliances with other institutions. This is needed. It's an overall comprehensive effort. One of them includes FDA. And as we look at the overall patient journey from the healthy living, the prevention, the diagnosis and treatment, it's important to also highlight, for example, what are FDA constraints and limitations and opportunities with respect to these novel technologies, some of them falling in the regulated field, some of those general wellness not regulated, but also many of them, which always implies a conversation not only with developers, but also with regulatory, the enforcement discretion space, okay? The gray area that food and needs discussion in ensuring that the product get to the patients. Happy to continue on the discussion. Thank you.
All right, well, thank you for that. And next we'll hear from Dr. Karen McConnell, the Chief Pharmacy Officer at Common Spirit.
Awesome, thank you, Dr. Clark. So moving on to the next slide, I just wanted to highlight that we are from one of the largest not-for-profit health systems in the country. So we have over 140 hospitals, over 1,000 clinics in 21 states. So, it's part of our mission to really take care of these most vulnerable patients. Next slide. And clinical pharmacy services are key in the management of all patients. Really, anytime that high-risk medications are involved, we have clinical pharmacy specialists on the team to make sure that they can treat these patients appropriately. One of the key areas that we have is we make sure that we prevent unnecessary exposure to opioids. So really try to nip this problem in the bud before it gets to an opioid use problem. But as you know, a lot of patients have already transitioned to that opioid use problem. So in our next slide, I want to highlight some innovative clinical pharmacy services that we're doing in the state of Kentucky. So Haley Bush, she was our first dedicated pharmacist to opioid stewardship. And we have her in Kentucky because it's one of our top 10 states for opioid-related overdoses. And so she is a key member of our telemat team in her hospital. Next slide, please. So as you know, it's best practice to not stop opioid therapy for patients who have opioid use disorder, but to treat it with evidence-based opioid agonists. And when patients are admitted for other indications, so they're in for a medical complaint or a surgical complaint, sometimes the medication-assisted treatment can be lost to follow up in the myriad of other treatments that they're undergoing. And while we can prescribe these opioid agonists, our physician colleagues are working with them to prescribe these for hospitalized patients. What is really hard is having the transitions of care. Next slide. So we have worked with a telemat company called Bright Heart Health to make sure that all of our patients who qualify for these types of services can get them in a telemedicine modality. Next slide, please. And my favorite part about them is they accept all payer sources and they'll treat all patients regardless of insurance status. The next slide, please. So the real key here is that when patients are admitted for these medical or surgical complaints, an MD places a consult to our opioid stewardship pharmacist, which includes the order for the medication for the opioid agonist. And that PharmD really takes that ownership of that order to make sure patients get the consultation they need, they understand the importance of it, they order the monitoring and any kind of adjunctive medications that they would need for withdrawal. Then they take that kiosk into the patient's room so that they can understand all of the things that they need to do for follow-up so they don't get lost to follow-up and they can really understand what is going to happen next in their care in the telemedicine space. And then the next slide just has a little bit more detail around all of the things that the clinical pharmacist does to make sure that the patients are as successful as possible and so they can get the treatment that they need after hospital discharge.
Great, thank you so much. And next, we're going to hear from Dr. Sethi, the anesthesiologist, CEO of Patient Premier.
Hello, my name is, wait for my first slide to come up. I'm still seeing dynamic here.
Those are
slide.
dynamic here.
Yeah, you might have to go, Bailey. Looks like maybe they were swapped. If you can just go forward till you see, yep, there we go.
There we are. Hi, I'm Amar Sethi. I'm the CEO of Patient Premier. I'd like to give you a couple of minutes give you a broad brush stroke of the world of digital health and chronic pain. Next slide. And next slide. Let's start with the standard pain diary to track patients. A lot of handwritten stuff that's not useful. My partner and I wanted to digitize it so it could be monitored and tracked over time. Next slide. And next slide, just a few screenshots of our solution. Assessments are distilled and delivered to clinicians who use the data to improve communication and care of patients. We help clinicians compliantly document and bill. Next slide. And the next slide. And the next slide. The need. We need to improve access and delivery of pain management to physicians and patients. A clinician-connected approach allows continuity of care while extending their reach. Next slide. This is because there's less than one pain provider per 10,000 chronic pain patients, a worsening problem. Next slide. 95% of chronic pain patients do not have access to a pain specialist. Next slide. And there's about 100 million patients in chronic pain, up to 1 in 5 Americans, depending on the estimates. Next slide. So we look at the world of digital health solutions in chronic pain. There are kind of 3 broad categories: consumer-directed, industry-directed, or research-created provider-directed solutions. So the consumer-directed options charge a monthly fee and look to cross-sell products and services. Research or industry-focused solutions acquire data to support interventions. And then finally, provider-directed digital health solutions assess and monitor patients on behalf of clinicians, typically for reimbursement or cost savings. Next slide. So we believe that payers determine physician and patient behavior through incentives. Time-based incentives are prominent to this new alphabet soup of remote care coding. Our job as an industry in this niche is to find different ways to bundle clinically appropriate services with communication tools, useful reports, and the means for them to be compliant. Next slide. And that creates our value propositions, at least in our point of view. Things like compliance, liability reduction, improved efficiency of care, reduced cost, and potential for revenue enhancement. Next slide. The future will take us out of these individual buckets and narrow windows to provide solutions to larger care populations. For example, we are integrating with CCM vendors and pill delivery device manufacturers. This will be important for us to expand beyond 5-state to nationwide solutions. And part of what I hope we get out of this call is that broader discussion of how to put these things together into that hybrid approach that Dr. Levy talked about originally. And with that, I'm going to turn it over to our moderator. Thanks for your time.
Thank you. And finally, we'll hear from Dr. Gastrand for his 3 minutes, and then we will get into some panel discussion and some questions and answers. I'd like to remind everyone to please enter your comments and questions into the chat bar.
Great, thanks so much. And Kelly, also thank you for your leadership in finding solutions, especially with regard to access to care. So there are a lot of technology solutions for people who use drugs, which is my focus. And these are uniquely capable of delivering quality evidence-based approaches. For instance, for stimulant use disorder, which is becoming a 4th wave of the current drug crisis beyond the opioids. And by the way, every time we've had an opioid crisis in this country, it's been followed by a stimulant epidemic. And so evidence-based approaches like contingency management or motivational incentives, where you actually pay patients money to achieve healthy behaviors. CBT we've mentioned, and environmental momentary assessment, where you check in every day or multiple times a day. One of the things technology is really great at is expanding access, but it can also substantially boost outcomes and upgrade the quality of care through remote use of software and computer tools and smartphones. Contingency management alone consistently tends to double abstinence rates in people who need to abstain. And it's automated and reliable. It really facilitates measurement-based care so that in between visits, patients can and they will self-assess, and they actually really like the opportunity to self-assess, and it improves their outcomes. But one of the challenges, will we be able to get providers to use those data? And in a number of these areas, we actually have trouble doing that. So could we incentivize providers becomes the question. And finally, can we incentivize the providers of these tools and clinical caregivers to work for outcomes? That is, if we can double abstinence rates with contingency management, we have a lot of margin for economically viable risk-based contracting. So that means we don't have to worry, well, when will we ever get there? We could get there now. In the next slide, I'll describe what we do in my company. Yeah, thanks. So Dynamic Air Health And I'm going to read this text, which is actually in the National Drug Control Strategy that just came out last week from the White House. So it's protocol-driven contingency management through smartphone and smart debit card technology. It provides automated appointment reminders and attendance verification, and automated medication reminders, drug, alcohol, tobacco, nicotine testing, self-guided CBT, and recovery coaching. So this is actually here and now. It's available. We actually operate in 45 states. We have 5 studies in the peer-reviewed scientific literature of scientists using our platform. We've achieved HHS Inspector General policy change just in the past month. We have payer coverage, including for direct full value monetary incentives paid to patients to abstain and attend treatment. And we're not the only ones doing these. There are a number of companies that offer components that I've described. SoberLink for remote breath testing with alcohol, Pear Therapeutics has been mentioned, groups, Affect Therapeutics, Chest Health, and so forth. So there are increasing tools and even integrators across these tools, like my company, that make this very feasible as an add-on or adjunct to conventional treatment, but doing all the things conventional treatment cannot do. And in the next slide, we have a number of needs if this is going to progress and really become a ubiquitous resource.
But I think, so David, I know we're at 4 minutes, so I think we're going to, I think this is a great slide for us to talk about sort of broad-based across the panel. And I think we'll make this, question 2 about what we need to do for tech deployment. But let me start with, what I think is question 1, which goes up to I think slide 3 in what Lou put out in terms of that overarching approach to the overarching approach of what are the virtual care. So Noah, can we get up to slide 3 again? So, because would like to ask you folks is, of all these kinds of tools and approaches that Lou described, where do you think the biggest opportunity for impact is in the pain and SUD space in the near to moderate term, 1 to 5 years? And then let's talk about what we're going to need to do that, both in your space and in those areas that you've identified. So anybody want to take a stab at this in terms of where you see these biggest opportunities for practice changes are? Lou, not fair going to you first because it's your slide.
Well, I could argue based on what we see with respect to company development, all of them actually becomes important. We saw a company developer considering maybe each of these tools separately, digital therapeutics, and then maybe some of them working on diagnostics. But as the FDA now establishing the digital health center, including wearable within that, I think it's really important to consider that the complex solution of all of them is to be considered. There is no algorithm without having a proper hardware component that will deliver the data, and there needs to be attention to that. You cannot just take any off-the-shelf wearable or sensor and give it to the patient. The patient needs to be accepting that. And then with that, will be the algorithm and the related therapeutics. But I see another.
Helen, were you addressing this? You have another question?
I just have a question when the time is ready. I'm good. I'm listening. Thanks.
Okay. Amar, were you going to address this?
Yeah. I can speak broadly to kind of pain. The way we look at the barriers, things that we need tools to overcome that make the physician-patient experience easier, overcoming the current barriers, basically. It can be facilitated, we think, by payers and EHR vendors, easier integrations, consistency in payments. There's just way too much consistency out there between CMS and all the national payers. And then specific ideas that we particularly look at: automated tapering, greater access to mental health and physical health solutions, easier transition to substance abuse disorder treatment for high-risk patients that we identify. I talk about these buckets that we're stuck in, and the idea that you can be in a chronic pain bucket but can't jump over to the SUD bucket easily is ridiculous. You should be able to go back and forth based on your individual needs as a patient. And just anecdotally, I'll say that, you know, sometimes you can measure the best effect by how you treat your patients that are kind of the worst off, the ones who suffer from disadvantage due to social determinants of health. We found that remote care has allowed us to interact with people who are kind of lost in the system much better than other approaches. We can measure their outcomes, and we can connect with them in a personal way that you can follow over time. And I feel like that's kind of where we all come together with common solutions that we can start working on as the time goes on.
Okay,
Yeah,
any other panelists want to jump at this? David?
I think the bottom line, most important transformation is value-based contracting, because for value-based contracting to work, you need measurement-based care. So it drives that. Measurement-based care requires remote patient monitoring, and it requires integrated management, which means collaborative care. At that point, you need tools or provider extenders. That's where digital therapeutics get driven, and other tools like digital diagnostics, e-consultation, and telepharmacy, which all fit into that. So if we could put the bounty up there for health and protect, you know, not just on a population basis, but across individuals, which is a challenge, that would drive all of these forward. And it wouldn't just be in the realm of NIH funding, which I'm tremendously grateful to NIDA and the NIH, you know, for 5 different grants on this work. But we really need the financial system to drive all of these changes. And then all of these buckets will start getting really filled.
Okay, so Karen, are you coming in to address that question, or something slightly different?
Yeah, I was just going to touch a little bit on telepharmacy, you know, and their role. You know,
right.
Clinical pharmacists have such a medication expertise, and oftentimes there's a gap for patients to understand why they're taking the medication, what they can expect from the medication, and what the outcomes that we are anticipating. And if there's that gap from the patient, they'll stop taking the medication, and all of this work that we've done on the front end will be for naught. And so really having pharmacists use telepharmacy to facilitate that education and that understanding for patients will help fill the gap, so we can see some, you know, fruits of our labor in this area.
Absolutely. Noah, can we go down to David's last slide on the barriers that we need to overcome, because we're going to pivot into that after Lou. You want to address the question?
Yeah, I just wanted to, you know, sort of double click on what David said in terms of value-based care, and that's absolutely where we are going in terms of our primary 360 program. And also to make the point that so many of the modalities that we're talking about in terms of digital solutions do not translate into, is this a level 3 or a level 4 visit? We're really talking about taking care of the individual 24/7, 365. And finally, just, you know, I've been a sailor for many years, and one thing that you learn sailing is you really need to respect Mother Nature and plan accordingly. And in terms of digital health, I'd say you really need to respect clinical workflows and plan accordingly, or else all of these solutions become pilots, they become projects. But as Amar has highlighted, you know, up to 20% of Americans may be suffering from a chronic pain solution. So one needs to get out of pilot phase and into scale phase. And that does involve, you know, a deep respect for clinical workflows, or else these become siloed and pretty much ineffectual in small scale.
Right. Well, the questions that we have kind of threw out at the beginning were, you know, where are the barriers and what do we need so that people can have access, but also so that that these technologies can be scaled. And those things are things from, more education on stakeholder groups on what modalities are actually evidence-based or what works, more getting rid of regulations and legislation that gets in the way, adding regulation and legislation to require, the same level of evidence-based care for addiction treatment that we require for every other care, for every other condition, including every other psychiatric condition. Is it, additional research that needs to be done to capture some of the data? And then what do we need to do to get at that research, since we have siloed out our claims data away so that it's hard to get at the single patient level? All of those kinds of things were sort of the next kinds of questions. And listening to Karen talk, I was struck with the issue that she's working with Braveheart, and we've had David, the founder and CEO of Braveheart, speak at the last session. We had Ankit Gupta from Bicycle, and I see a chat here from Lisa McLaughlin. She's the founder and CEO of WorkIt. There are other multi-state groups doing TBOT, Ophelia. There are a number of those groups that I do want to mention, as David kindly put into his slide deck, the number of different companies that are out there doing this kind of work. But one of the things that gets in the way of doing this in where I live in Kentucky, where this work is that TBOT is not just allowed unless there are in-person meetings from physicians in the same group. So somehow some legal piece has been worked out with the hospital in Kentucky and the TBOT provider, so that they're comfortable prescribing without that in-person from the TBOT provider. So some of those things I think are really important for us to capture in this, some of those problems and then the workarounds. And I think David has kindly in his slide laid out some good talking points around there. But anybody want to address some or any of these kind of briefly? I know each of you could talk for 20 minutes around what needs to happen in here, but can we throw some spaghetti on the wall and capture these, please? And again, not starting with David, with you, because it's your slide, so that's not fair. So Leonardo, you had your hand up. Did you want to take a stab?
Yeah, and I wanted to emphasize there is a comment in the chat regarding the tools. As an engineer, I certainly see that, and what we always recommend developers think to what the patients would use. And we have seen examples. VR is expanding as a great tool for pain and possible opioid sparing pain. But there have been studies, reduction of pain, no change in opioid because it doesn't integrate in the clinical workflow. So really, again, and the type of VR setting, whether it is augmented reality for pediatrics or the full system, depends on what the patient would use it. So I can't emphasize that. And with respect to this, I wanted to maybe just touch base on the last bullet point regarding FDA regulation. Our message to applicant grantee that come to NIDA is we don't see FDA regulation as the ultimate goal. We see that as one step. The goal is to get the tools, the patient to patients. If the best path is as a consumer product, non-regulated by the FDA, as long as there will be some customer willing to pay, that is okay on our side. But there needs to be a clear message, and this is where FDA needs to be involved in the claim that the devices have. And it's also, this is a very changing field. Digital health within the FDA is changing over the past 2 or 3 years. So it implies really a conversation with the FDA. What is the tool? What is the claim? What is the clinicians or claim clinicians needs to use? And then go from there.
Thank you.
Yeah, I'll echo what was just said. We find a lot of inconsistency, and it's mainly because the knowledge is changing rapidly out of the FDA. But what needs to be regulated? Is it an EMR? Is it a clinical decision tool? Does it need regulation? Is it software as a medical device, or is it actually need FDA 510K clearance? And I find that what I read, what I hear about from regulatory lawyers, and what I perceive comes out of the FDA seems to change rapidly enough that it gets confusing. And part of the issue is really just cost. The cost for each of these pathways is drastically different, and it becomes onerous for a small company to overcome. So clarity in that regard would be very useful.
Great.
There's
David?
another limitation to the FDA regulatory process, and that is a company has to lock down its protocol, its algorithms, how it manages the data, its features, and then submit. And that results in a company that's marketing something that's 15 years old now.
Yeah.
Is that the best way to use technology? What do we do when, machine learning analytics say, no, revise this protocol? You have to start over with clinical trials again. So there are some limitations besides just the prescription access.
Great
Yep.
points. Anybody want to deal with the federal state regulatory obstacles and the workarounds that are needed, what needs to be changed, and how you can deal with it in the meantime? Anywhere in your space. I already gave Karen's example there for TBOT in Kentucky.
Yeah, certainly we see this all the time in terms of having a national program and having to deal with various federal and state regulatory issues. And I think it's just really a plea, if you will, for the state regulatory authorities really beginning to work much more in conjunction with each other. Just to arrive at some consistency, because at the end of the day, the individual who's suffering from chronic pain or a substance use disorder and living in California is not all that different from the same individual living in Arizona. And yet we do have these diversity of regulations at the state level, which just make bringing solutions to scale more difficult, as well as obviously licensure questions as well.
And the payment questions that go along with that too,
Absolutely.
from county to county, even within the same state.
Mhm.
Yeah, and it also extends to reimbursement, where even as recently as the public health emergency, where certain payers would have certain rules enacted in terms of their payment of clinicians who may have been working under a temporary guidance in terms of their ability to provide medical care. So I think that a lot of a plea towards, make things different when it makes sense to make things different, but try to always aim for consistency from state to state.
And I would just add, I think some of the X waiver requirements make it really difficult for some of our patients to get the medications that they need. And having those providers that have the X waivers available in rural areas or places where patients are indigent, make it harder for them to get the medication they need on an outpatient basis. So I think taking a look at those laws, while I believe they're not as stringent as they used to be, there's probably still some room for improvement there.
Okay. Anybody else want to take some stabs at what we've got left? We've got 15 minutes for this, 14 minutes left for this conversation. Now, I know that there.
Thing that we're seeing, this is Amar, patient premier. On the flip side of that coin that was just discussed by Dr. McConnell, patients are having a harder and harder time getting necessary pain medicine because there's a lot of barriers, limitations on prescription length, limitations on pharmacists' ability to dispense and fill medications, requirements that vary about the nature of the prescription. Can it be e-prescribed? Does it have to be handwritten? How often does a new handwritten prescription have to come in? Patients are kind of stuck in the middle and they're getting very frustrated. And while that is perhaps outside of the scope of this conversation, it did kind of fit in a little bit. And if there are any solutions to that people have heard about, I'd love to hear them.
I wanted to actually echo that, because as supporting developing of tools, what we also already heard from patients is this idea that they are somewhere concerned that the traditional care would be taken away from them in favor of these new tools, whereas in fact, it's really a complementary approach. These are adjunct therapies, and the one have been clear as adjunctive, but most likely they will remain as such. So it's really a complementary tool integration that may address also the point 2, rather than, okay, here is something completely different. And well, during the pandemic, we saw certainly telehealth arriving to many. There were still some population that was not reached out by these tools, maybe due to digital literacy or not access to smartphones. There is still 10% in the US that does not have access to those tools. And we need not to forget about those.
There are really two things though, aren't there? I mean, there's digital technologies that are supportive and complementary to what we might have considered to be traditional care. And then there are those that really are their own thing, that are not traditional care. They provide something that traditional care is incapable of providing. So isn't it less of a how to integrate this into what we have, and rather look through all of the different things that we have and then choose from those how to build an integrated type system?
I think in providing a portfolio of options to the patients. So making sure that anything you do comes also with education to the community, education to stakeholders, education to the FDA. Spend 10 years with the FDA, there is possibility of innovation, of new tools, but again, it's a conversation that needs to occur across the board. And really providing options, clinicians, patients, developers, and what is the best strategy. Just like a kid would prefer to have a augmented reality solution on a kind of a Pokemon based rather than a full VR for pain.
Sure.
Yeah.
I'll just add, I think one of our biggest struggles, because we serve so many indigent patients and those that are vulnerable, is their access to technology. You know, one of our speakers said, 10% of people don't have an iPhone, a laptop, access to the internet, a place where they can go and engage in these services. And oftentimes we see them in our EDs because they have no other way to get care. And even if we're able to facilitate telehealth or telemedicine or telepharmacy after they're discharged, and they have no way to access that, they're back in our EDs again, in an overdose situation. So I think what we really need to look at is some kind of US technology infrastructure that's easily accessed for every single person, and not just those who are able to afford a cell phone bill or an internet bill.
Yeah, we've run into that problem quite a bit. And we've found solutions. For instance, the Affordable Care Act actually provides for cell phones and plans at a low cost, but more than enough technology to operate everything we need. And so we can provide those, but the access for the patient and giving the patient the understanding is a real challenge. And Karen, you talked about pharmacists and their role in extending the information flow to the patient in the inpatient setting. Peer navigators or certified peer recovery coaches can be trained, this is what we do, to take, we have people re-entering society after 15 years in prison who haven't used a smartphone, much less getting them one. So, it takes a longer stretch of time, weeks even, of practice and reviewing with them to get them to master the basics of the technology. But it's very doable. You just don't want a physician to have to mess with that stuff, right?
That's right. That we're not doable at all on that. You can just count us out on that.
No.
We're not educatable. I want to go up to Iris's question, but first, would anybody else like to address what you've done to try to address that digital divide, the way that David just gave some examples?
Yeah, I've got a quick example. We had partnered, this is Amar, we partnered with a company that delivered phones to patients who didn't have phones, but delivering them wasn't enough. Then we had to go train them, and it became a real barrier on the part of that solution provider to make this work for us. It's true, our incentives are different. We're time-based incentives now. So we have some incentive to connect with patients, but it wasn't enough money to make it work, unfortunately.
A couple of things that we've done at Teladoc Health. One is we've always been very strong advocates of the telephone as being a means of providing virtual care. When I think it was quite popular for many years to basically say that a video visit is the only legit way of delivering virtual care. So we've been very strongly on that. And the second piece, I think, is really around engagement of marginalized communities and being very creative, because all of the solutions in the world don't really work too well if nobody is actually utilizing them. So things as simple as home mailings, putting up posters in laundromats that tell people about the availability of a service, and thinking about creative ways to get your message out there other than putting things on, say, Facebook or Twitter or other internet sites where the individuals might not have any internet access. So really trying to get that message into communities.
Right.
Very
I know
briefly.
that at my state level, there's going to be a vast difference between audio visual in general for telehealth and audio only for prescribing of controlled substances. There's at a state level, I just think that's going to be a really interesting space, just given my experience here. So
very briefly,
Iris, I think you've got a question up here, and then got a couple more questions to go, which is great.
Oh yeah, going along with the comment that I wrote in the chat is that, hi everybody, I'm the Vice President for Telehealth for Northwell Health. You know, we do have a substance use disorder and pain management program that is an integrated program. It's small, but it's something we started with. But you know, the challenge I really think, along with all of the regulatory pieces, is we can now be in the same place at the same time, and we keep segregating everything into these different silos. But you could have all of your specialties on one telehealth encounter, but we need to be able to have the billing mechanisms to make that happen. Because if you try to drop a bill and two providers saw the patient at the same time, they can't both bill. Well, no, that's not true. We need to be able to change all of that. But in addition, it's that coordination of care and having a care navigator, because I have a family member going through this right now, and she has been to no less than a dozen different specialists to try to get to the source of her pain, still suffering, doesn't know who to turn to, and she's doing it all on her own, navigating through multiple complex health systems. This is why people turn, one of the reasons people turn to self-medicating. So they're very much related, and we need somebody to help navigate. So we need a role recognized, a specialist that can actually help them to navigate and has the connections to all of those different modalities. So we're not just talking about, you know, prescribed medication. We're talking about psychotherapy. We're talking about physical therapy. We're talking about any kind of ology you think of that might help. And so in planning those connections, if we think of a hub and a spoke model, I'd like to think of the patient as the hub, and everything comes to the patient at the same time. I think if we start designing with that in mind, we're going to have a lot more success, because as patients have to wait, 1 week I'll meet with this person, even if it's telehealth. Yes, we're taking away their travel. But the beauty of telehealth is we could actually, just as we're all on this camera together here today, do the same for the patient and bring all those disciplines to them. It's not easy to do, and this is what I keep hearing. It's too hard to coordinate all these different schedules, but I feel like we have to be able to figure it out and be able to do it. I mean, there's a lot of advanced scheduling systems out there, so maybe that's something that we could talk about from an innovation standpoint to help the patients.
Thanks. Leonardo, you had your hand up before. I think I cut you off when you were about to.
Yeah, no, very briefly for the topic of addressing digital disparity and inequality, we actually have specific funding opportunities related to encourage mobile health development to address digital inequalities, which we support novel technologies, but again, is the point of what is the real need of the patient and what is the best and most effective solution.
Great. Well, I think Helen, I'm going to pass on you for the moment, because you've got put that in the chat, and I'll encourage people to continue this discussion in the chat. As we've got only about 4 minutes left, we'll go for our last question up to Charlie.
Thank you. Yeah, I find this a great discussion, because people are expressing the different perspectives and the challenges, how to bring all these together into a integrated solution. As we in our company were developing our telemedicine, telediagnostic solution, we did center on the patient. You know, it's a patient-centered approach for the services that we believe a provider would like to provide. then we started working with providers, different kinds, as to what they wanted to do over our platform. And we found that for different illnesses, different ailments, we had to add specialty items for the patient to increase the amount of diagnoses that could be done for the patient to be in one location, remote from any brick and mortar. And that is starting to come together. And I think the opportunity to interact with one or more of you as time goes on, I think we'll come closer to what we believe we have in the way of an integrated solution.
Great. Well, we are actually at the end of our time, and we've got I think we're taking a 10-minute break after this. So folks have a chance to get their breath for a minute. And we're going to come back at 2:20. But I would like to take the opportunity to thank all of our panelists for the presentations and for giving us some robust information that we captured. And to you folks for getting your hands up and getting information in the chat, which is what we're really hoping to do in this series. So we're off to a phenomenal start. Thank you, everyone, and enjoy your 11 minutes. We'll start again at 2:20.
And good to see you.
Good to see you too. Oh,
Thanks for doing this.
thank you. I'm excited. For those who are on, we're going to start back in about 1 minute. Okay, it's 2:20, so let's go ahead and get started. Welcome back, everyone. My name is Ann Burns, and I'm going to be the moderator for this second session, which I think you'll find of great interest because it's really going to be delving into reimagining the care team. The format of this session is that we have 2 guest speakers who are each going to speak for 5 minutes, and I will introduce them in just a minute. That will be followed by 25 minutes of facilitated discussions, and we would also obviously encourage you to continue the discussions in the chat throughout the entire session. The first 2 meetings of the NAM's telehealth initiative focused on the perspective of patients and caregivers. And then the second one focused on policy, payment, and regulations. And we've seen smatterings of questions related to those 2 topics. But I would say from participating in both of the first 2 sessions, there was this underlying thread of how can we use telehealth to coordinate care? And so this session is going to bring to light 2 real-world examples of how telehealth is being used to coordinate care in both the pain management and SUD realms. We're going to be talking about best practices, successful strategies, lessons learned, how does the hybrid model work, and what are the barriers that impede implementation of integrated hybrid team-based care? Our first presentation for this session is going to focus on telehealth-enabled team-based care related to pain management. And our featured speaker is Dr. Addison Regan. She's a clinical pharmacist and the National Clinical Resource Hub Pharmacy Manager within the Department of Veterans Affairs, which is a program that provides clinical services through virtual care, in-person care, and mobile teams through a combination of primary care, mental health, pharmacy, nursing, and other specialty providers. Our second speaker is Dr. Tran Tran, who is going to focus on telehealth-enabled team-based care implementation for SUD services. Dr. Tran is a clinical pharmacist who serves on the substance use intervention team at Rush University Medical Center, which is an interdisciplinary consultation service consisting of physicians trained in addiction medicine, advanced practice nurses, licensed social workers, and pharmacists working together to identify and treat patients at risk for opioids and other substances. So without further ado, I will turn the program over to Dr. Regan.
Thanks, Ann. So I'm super excited to share a really innovative hub and spoke model that we have implemented in the VA and how we have now expanded this model to include telepain. Next slide, please. Just to give you a little bit of background, subsequent to the Mission Act in 2018, the VA was really looking at a way to improve access to our more rural veterans. And they really decided to leverage telehealth and develop what we are now kind of terming the clinical resource hubs. And we have one of these clinical resource hubs in each of our 18 networks or regions. And initially, these clinical resource hubs, which is really a repository of clinical and support staff, primarily providing virtual care, really focused on primary care and mental health. But in the last year to 18 months, we've really expanded into specialty care, and in particular, telepain, pain care, primarily because, as we've already talked about this morning, specialty pain care is scarce, and it is also scarce in the VA. We have some pain teams, but not enough. And we also often don't have these resources in the community. Next slide, please. So we had a couple of programs early on in our clinical resource hubs who kind of dipped their toes in telepain. And one of these is primarily a prescriber model in one of our Northwest networks that used a pain clinical pharmacist practitioner, as well as a behaviorist and a physician champion, to really help manage chronic pain for the veterans in that region. And during that year, they managed approximately 200 veterans through a hub and spoke telehealth model. And you can see had some really great outcomes in getting patients started on Suboxone and reducing opioid dosages. Next slide, please. And similarly, kind of at the same time, there was a behavioral health model within our clinical resource hubs that really looked at providing behavioral health services for pain. And you can see here that, was very successful in particularly reaching our rural veterans who did not have access to these services. So thinking about those kind of pilot models, next slide, please, combined with the fact that we did a national survey of our VA medical centers and found that 50% approximately of those medical centers lacked adequate step 1 pain care teams and step 2 pain care teams. So integrating telepain into our clinical resource hub framework, which already existed, seemed like a really great way to improve access to pain care for our veterans who otherwise were not getting those services at their medical centers. Next slide, please. So we have a model that had a very robust interdisciplinary pain management team composition. And you can see all the different kind of disciplines listed there, which we encouraged all of our CRHs to consider when implementing their pain management teams. And we had 12 of our 18 clinical resource hubs actually decide to go ahead and integrate a telepain team into their clinical resource hubs, with all of them really integrating this full, robust interdisciplinary team. Next slide, please. So I totally recognize that this is a really busy slide, but I really think, and I wanted you to have a copy of it, it really kind of helps conceptualize this idea of the patient care journey through a telepain program and how we are anticipating integrating both virtual care and on-site care in a multimodal approach. So, just looking at the big boxes, so the patient presents to one of our primary care mental health clinics, and the patient's complicated, they have complex pain needs, they really need an interdisciplinary team approach, but those services aren't available at that small community rural-based clinic, and the patient can't drive to the main medical center. So the clinician is like, great, we have this interdisciplinary team that can virtually support you. And so they place a consult. The interdisciplinary pain team says, yes, this patient would be a really good candidate for our program. And really the next step, I think, is the most important step, where this team huddles together, looks at the chart, decides what services this patient may most benefit from, but then has this really virtual kind of group visit with the patient, where the patient is part of that care planning process, with the goal of hopefully the patient being able to have at least one behavioral therapy, one movement therapy. If they need comprehensive medication management, that will be included, and using the RN on that team to really integrate the care and coordinate the care with the on-site facility and the community. So we know things like labs, procedures, a lot of our movement therapies may need to be delivered actually in person, or interventions, right? So coordinating what's going to be cared for at the site, leveraging those services, and what can our telehealth team support. And then finally, hopefully getting the patient functioning, their quality of life improved, and then handing that patient back to the on-site team at approximately 6 to 12 months after they're completed kind of the telepain program. Next slide. So just kind of key takeaways and next steps. We've had early demonstration that telepain care can improve access to specialized pain care and MOUD, and that interprofessional, interdisciplinary care, pain care can really benefit underserved areas and may help improve health equity. And this idea of this hybrid model, this mixture of on-site care alongside telehealth care, may be optimal really for a multimodal approach. This kind of aligns well with the CDC guidelines, which say telehealth can be incorporated into pain management strategies. And this program, of course, is in its infancy, and we anticipate hopefully that this will help provide some much needed evidence to support the delivery of comprehensive pain care via telehealth.
Thank you, Reagan. That was great. Now we'll turn to looking at an example of a team-based virtual care model with Dr. Tran for SUD.
Thank you. Thank you, Anne. It's a pleasure to be here. Next slide. So SUD treatment requires individualized care with coordinated management of coexisting chronic conditions. A team-based, patient-centered approach enables a healthcare system to provide better care and promote healthier people and communities. The workflow that we have at our institution requires a 2-question screener that is done by inpatient nurses, an in-depth assessment using audit or DAST with inpatient social workers, who then either provide brief intervention and follow-up or a consult to the addiction medicine service. Our addiction medicine service at our institution is called the Substance Use Intervention Team, the SUIT team. We then either initiate pharmacotherapy or provide other resources, and then also operate an outpatient clinic in which we monitor their maintenance therapy on the pharmacotherapy. Next slide. Sorry. You can see in the purple, our substance use intervention team or addiction medicine consult team consists of an attending physician who is actually trained in toxicology and emergency medicine, an advanced practice nurse who is also trained in psychiatry, an inpatient social worker who is trained in motivational interviewing and also provides cognitive behavioral therapy, and then the clinical pharmacist, who is me, who's also a faculty member at the College of Pharmacy. Our team also helps oversee the addiction medicine clinic, which is in the yellow. In general, pharmacists oversee the comprehensive medication management, otherwise known as CMM, and the medication use process to ensure that the medications are available at the institution for optimizing patient care. The role of clinical pharmacists in optimizing substance use disorder is primed to expand dramatically over the next decade. The total physician shortage is projected to fall between 54,000 and 139,000 physicians by 2033. And there's expected to be a shortage of primary care physicians between 21 to 55,000. With extensive medication knowledge, clinical pharmacists integrated as accountable members of the care team improve team efficiency and achieve medication optimization. When clinical pharmacists engage in patient care to their fullest capacity, physician time is saved, access to care is expanded, clinical outcomes are improved, and payers experience financial savings. Next slide. Avoidable illness and death resulting from suboptimal medication therapy leads to an estimated 275,000 in needless deaths annually and contributes to nearly $528 billion in healthcare costs, which is equivalent to about 16% of annual U.S. healthcare expenditures. Medication optimization occurs through comprehensive medication management, or CMM, to avoid misuse, overuse, and underuse of medication therapy, which can lead to treatment failure and new medical problems. In addition to reducing costs, CMM is associated with lower hospital readmission rates and improved clinical outcomes for a range of chronic conditions. Clinical pharmacists are responsible for CMM in team-based patient care environments. Individuals with complex chronic conditions benefit most from CMM, and individuals with substance use disorder have a high incidence of complex comorbidities. CMM services for SUD have demonstrated a positive impact on access to care, quality of care, patient engagement, patient satisfaction, and treatment retention. Medication plans for CMM that are led by clinical pharmacists as part of interdisciplinary teams include clear and measurable goals of therapy with specific follow-up timeframes to ensure optimal medication use and outcomes. And delegated authority through collaborative practice agreements or collaborative drug therapy management confers specific privileges, responsibilities, and accountabilities to clinical pharmacists that propel efficient team-based care. Next slide. So I just want to show basically using the episodes of substance use disorder care that's been outlined in the Alliance for Addiction Payment Reform. There are 3 critical interconnected episodes: a pre-recovery stabilization episode, a recovery initiation and active treatment episode, and a community-based recovery management episode. As integral models or members of the care recovery team, clinical pharmacists positively impact outcomes in these episodes across the continuum. So for instance, for episode 0, the pre-recovery and stabilization period, the patient that I had kept refusing treatment, but we had full access to try to engage them multiple times in the hospital, and also access to IV buprenorphine that was added to formulary to allow us the safety of microdosing and treating breakthrough pain. Telehealth allowed the pharmacist to recommend to the team a buprenorphine dosing schedule to transition the patient with prolonged QTC from methadone, and speak directly to the patient to offer extra support despite being at a different location. Next slide.
Tran,
Yes.
you're out of time, so
Okay.
maybe we can focus on some of this information during the Q&A.
Sure, no problem. That's fine.
Okay. What I'd like to do now is open it up for Q&A. Oh, sorry, I'm seeing a note that, do you think you can wrap up in the next minute? My apologies.
That's okay. There's just 2 quick slides. So basically, I'll just go through episode 1 for a substance use disorder care. It's focused on the inclusion of the patient into treatment following the stabilization period. This first episode promotes strong connectivity between clinically appropriate institutional settings and the underlying care from the team-based model, working to promote active recovery. So for instance, with the pharmacist, I had 3 visits last week. The clinic's telehealth services is helpful for patients who just need extra touches and extra support, but can't be seen in person. One patient wasn't taking her medications and needed emergency care several times during when COVID-19 cases were increasing. So I described to her how to administer the medication sublingually for the full effect, and how to time her medication with her meals to help remember and to optimize her pain control. And then the last slide just talks about episode 2 of SUD care. And this episode focuses on the patient's integration into the community and the continuation of a treatment and recovery plan. This episode represents the highest risk to the provider, as a failure to adequately engage and support the patient could lead to high cost avoidable recovery disruption. So basically, as a pharmacist, I've been checking in remotely with this patient pretty much every week. Most of our encounters are just kind of chatting about how she feels and reinforcing why she needs to be taking these medications and how much better she feels when she does take them. And she's been able to stay out of the emergency room the last couple of months now. Although medication management has been tied to transitions of care payment structures, CMM needs to be formally recognized as a compensated chronic care service and evolving payment models. CMM has the potential to provide or to help healthcare providers maximize performance-based payment payments, and CMM aligns closely with quality improvement initiatives to achieve the national goals of better care, better health, and affordable cost. And that's all I had. Thank you.
Great. Thank you so much. Now we'll open it up for Q&A. Feel free to type comments or questions into the chat, or raise your hand if you would like to ask a question directly. I know one question that has come up today and in previous sessions is when working with a telehealth model or a hybrid model, how do you manage all the different moving parts, especially when a primary focus is on coordinating the care?
And I can take a first stab at that. So this was something that we really considered in our VA model, and really based off of our experience with the pharmacist-led prescriber model, recognized a need for that care coordination piece. And I think somebody even mentioned earlier, that's like a specific role. And so that is the primary reason that we recommended that we have an RN, preferably one that was trained in pain, be part of our telepain teams to coordinate the care between, you know, the VA medical center and our team, as well as the community. And because there's so many moving parts with scheduling, with ordering appropriate tests, with labs, with even getting outside VA medical records, that you really need that person to be the kind of glue that holds everything together, as well as the person that triages that first triage when the consults are received within the VA. So I really can't emphasize enough how important we think that RN care manager role is within these interdisciplinary teams.
Mm-hmm.
And I believe you also mentioned, Addison, that you actually have meetings with other providers and the patient in one session, and we all know there are payer challenges to that, but have you noticed outcomes from that, or do you have any data that shows that has an impact?
We don't have any data yet, but that is, we have an evaluation team specifically kind of charged with looking at our telepain outcomes for this model. And that is definitely one of the areas that they're going to look at around patient satisfaction and how the coordination of care influences those outcomes, such as, you know, relapse for, you know, SUD and, you know, pain functional status. So we do plan to look at those. The model, the telepain model where they had behavioral health, that pilot used that process of having this kind of group visit, right, with several of the clinicians, even the on-site clinician and the patient early on to establish that care plan. And what they found was that the patients, they loved it. They loved hearing all the options of being part of the decision-making process, right? Where we're enabling them and empowering them. And I think we've heard before how frustrating the pain journey can be for patients, and it can be frustrating in the VA too. And this is like concierge service, right? You've got all these different disciplines, and they're actually meeting with the patient to discuss the plan because the patients often feel out of the loop.
Thank you. And Tran, from your perspective.
So I was just going to tack on to what Addison said, you know, on the inpatient side for our addiction medicine consult service, the ability to kind of round remotely has been tremendous. We have so many trainees that attend rounds. And then me, a little bit more about my role. I'm a faculty member at a university or a college of pharmacy. And so I lecture and I have responsibilities that are on campus, but being able to round on every single patient, every single morning has been tremendous. I'm just able able to be there more and provide my services much more. So that has made things easier and made it easier to incorporate a role for a clinical pharmacist to be there more consistently. And then on the outpatient side, it's been great to be able to counsel patients virtually on naloxone and just provide some additional support, and to maybe touch patients more frequently than they would normally get touched with, the traditional members. So it's been wonderful, but I will say that our team is really tight knit, and we talk all the time, and we are on chats through the electronic health medical record with everybody. So we are in the loop with every single patient, and I think that's really helped a lot. Mm-hmm.
Great. Addison, I think you touched on this, but how do you determine the mode of care delivery for each patient?
So, we primarily try to do the majority, if not all, through telehealth modalities. However, we've touched on this, like with the Controlled Substance Act and the Ryan-Hayden Amendment, sometimes if the patient is on controlled substances, then, and depending on the state regulations, the patient will need to be seen in person by a prescriber for that opioid, or the patient may need a procedure like an injection, right? So it depends on the patient needs, the particular medications that the patient's on, et cetera. But all the psychosocial, the cognitive behavioral therapy, those are all able to be delivered through telehealth. And we have physical therapy and some of those movements that are able to be delivered through telehealth, but if the patient, let's say, might benefit from acupuncture, obviously that would be something that would need to be coordinated with a site. So it's very patient dependent. And so that's part of that initial kind of triaging, right? Like of those modalities that we have and the different services, which of that needs to be on-site care and which of that can we manage virtually through telehealth.
Thanks. Tran, did you have anything to add?
Sure. I mean, it's very individualized. Some of the medications that we start patients on are the long-acting injectables. So in clinic, we have to see them in order to administer those medications. For other patients, they are far away. Like we have pockets of communities that don't have access to X-waiver providers. And so we kind of like fill that gap. And in those circumstances, we cater to them to allow them to access us virtually more frequently than maybe other patients that are that have a better transportation. So
I smiled when I saw the comment in the previous session around all the difficult laws and regulations in pharmacy related to prescriptions and controlled substances, because pharmacists live this on a daily basis. But I'm wondering if both of you could comment on your experiences with some of the waivers of flexibility related to controlled substances during the pandemic, making them available to patients and so forth, and any thoughts you have about where you would recommend future directions go based on what you're seeing in your practices.
So that's like the $1 million question. Even in VA, and I know I saw Dr. Galpin, and he's really leading our VA efforts. So I'm sure he can probably speak to this as well. But in the VA, pharmacists actually work under our scope of practice, so we can prescribe under our own names. But this whole issue of prescribing controlled substances via telehealth is relevant across the board, no matter the clinical discipline. And in the VA, the way the Controlled Substance Act is written, we have to follow both federal and state regulations. And in VA, that's the state in which our doctors prescribe in. And that's, I think I saw Dr. Galpin say, that's very confusing because every state has very different regulations. And so if the state in which our VA prescribers are licensed is more stringent than the federal Controlled Substance Act Ryan Haight Amendment regulations, then they have to follow those state prescribing regulations. And what's happening currently is many of the states have reverted back to pre-pandemic rules and regulations, which have eliminated some of the telehealth provisions. And so, you know, one of the biggest ones is being able to prescribe controlled substances through telehealth and to the home using any, you know, video, audio, visual, you know, modality. And so in the VA, that was huge. We were able to really provide controlled substances through telehealth into the patient's home during the pandemic. And so now that states are reverting back, and then there's, you know, questions around what's going to come out of the federal side of things, right? Once the pandemic declaration of health emergency ends, like we're really scrambling to figure out, you know, a path forward to help, you know, maintain good access for our patients.
Yeah.
So for us, two things, with methadone with people being able to take greater amounts of methadone home for take homes, it's made the role of the clinical pharmacist even more important, because we can no longer call the clinic to ask them, you know, what was the last day that they arrived to clinic to get their methadone. And we know that the tolerance to methadone drops precipitously even after 2 or 3 days. And so the pharmacist really plays a big role in capturing exactly when that last dose was taken, to make sure that, you know, when they're hospitalized, they are put on an appropriate dose that doesn't put them at risk. Another thing is increased access to initiating buprenorphine through telehealth has increased the number of patients that we have on our service or taken care of by our team, which means that we need more manpower, right? We need more resources. So it's been huge. I think we've been able to provide access to more patients, but then we also, our team works harder because we have to see many more patients and make sure that we give them the best care. Mm-hmm.
And I'm gonna ask both of you to comment on a comment in the chat, but I would also encourage others who are in this session to either raise your hands or in the chat, share any innovative models that you might have for hybrid care for both pain management and SUD, because we'd like to get as many examples out of this meeting today as possible. So the comment that was in the chat, and sorry, I'm trying to do this on my computer and talk at the same time. So a question, naive question, can clinical pharmacists create guidelines, protocols where trained MAs can provide this service instead? That would fit into existing billing codes while allowing this type of team-based care. Just wondering if either one of you would like to comment on that.
I can comment on that. And Keith, that's a great question. I think it really depends on what service you're talking about. If you're talking about naloxone counseling, yes, we do that currently. We train a ton of our MAs to go out in a lot of the primary care offices to provide this training. And we make sure that we're accessible if they have questions. But a lot of the other things that clinical pharmacists do are a little bit more elaborate than that. And so they don't naturally fit into protocols or guidelines. And so it's things that are like targeting medication adherence and helping out with, I don't know, access to medications. A lot of these medications are like restricted distribution, and it can be a little bit more involved. So I guess short answer to your question is that it would really depend on what service. And then I also just want to make, I think that's since there's no billing code for pharmacy services, that's a problem. We should really tackle that instead of, trying to get instead of getting MAs to do the work and being able to bill through their services. Mm-hmm.
Yeah, and I'd just like to add, I work at the national level around pharmacist services, and comprehensive medication management often involves assessing all of the meds that the patient is taking. And we know that a lot of patients with pain and SUD have a number of concomitant conditions where their care is not coordinated, there's duplicative therapy and so forth. So it really is a higher level of cognition with a lot of the services, if I could take the moderator's prerogative. There was a follow-up question about the role of pharmacy technicians. So I don't know if either of you would like to tackle that one. And then I know Liz Bentley has her hand up, so we'll do that next.
I can speak a little bit about the pharmacy technician. So in the VA, we have expanded the role of the clinical pharmacy technician to do some of the legwork, if you will, of gathering information and putting it in a nice, neat package prior to the visit with the clinical pharmacist. You know, we are very lucky in the VA to have many dashboards, really great pain management dashboards, and using that technician to kind of do population management to identify high-risk patients, to identify patients who've not had a PDMP or maybe are lacking, you know, a urine drug tox, and kind of teeing those up for the CPP is a really great role. So you don't have that clinical pharmacy practitioner spending kind of valuable time, you know, combing and doing population management. Also, when you think about technology, using, I didn't mention this, but using a telehealth technician, sometimes even using that clinical pharmacy technician can often be the bridge to helping the patient with the technology, getting that video visit established, like starting the video visit for the clinician and then handing it, you know, kind of virtually to that clinician is an amazing use of time, and it saves that clinician the frustration and the patient, right? Even if it could be done ahead of time, the frustration that sometimes comes along with those technology barriers. So I think there's a lot of roles for technicians. We're using intermediate care technicians, clinical pharmacy technicians, telehealth technicians to do a lot of the you know, kind of technical work to help the clinicians spend their time evaluating, assessing, monitoring, right, the patient.
Yeah. Thank you. Liz Bentley.
Hello, really
Hello.
just piggybacking on what's already been said and completely agree. It very much depends on the situation and what you're looking to accomplish. And just with our core model, which is multidisciplinary, we've modified at various times based on what seemed to be working best. We've always had pharmacists and the physician leads as the core. We've rotated through having nurses, social workers, pharmacy techs, and right now we have a social worker as our primary touch point for onboarding, and that seems to be working very well. I think, you know, there are many options that can work. And the one caveat with pharmacy technicians is considering your state of practice and any scope of practice limitations and what's specific to the state, because it does vary quite a bit. However, completely agree, having those clinical pharmacy technicians can really extend your reach as a pharmacist, not just in this area, but in other areas of medication management.
Thank you so much. And I noticed there was another description, I think Lisa, in the chat. We are about 2 minutes away from the end of this session. So Addison and Tran, I wanted to give you the opportunity to provide any closing thoughts, and then we'll open up, or we'll close this session and open the next one.
I guess I can go first. I just really am excited about this VA model, this hub and spoke model, and around, you know, this robust interdisciplinary team providing, you know, specialty pain care to veterans who would otherwise not have access to this kind of multimodal approach. And I'm hopeful that some of these regulations around prescribing controlled substances across telehealth can be addressed in the next 6 months because that by far is our really biggest barrier, and heartburn amongst our prescribers and clinicians as well, because there's so much confusion to really, I think, making this a very successful model.
Thank you. Tran?
Sure. Just real quickly, our pharmacy technicians can do like med reconciliation and prior auths, and that's helpful to have them do that. But I really want to harp on the point about comprehensive med management. I mean, it is so important, and it can really optimize care. And I can give you a ton of examples, but we only had 5 minutes. But I guess I just want to emphasize that having a pharmacist provide that comprehensive med management as an interdisciplinary team is crucial and is so important. And I think it becomes overlooked sometimes because I don't know, I guess our role is tied to like cost savings through adverse event avoidance. And so sometimes there's not always the support to provide a clinical pharmacist. But now with telehealth, we can make clinical pharmacists much more accessible. And so I hope we move in that direction. That's all.
Great. Well, I would like to thank both of you for your presentations and your feedback and input, as well as all the great comments and questions that we received in this session. So this officially ends session 2, and we will be moving on to session 3. And I believe I'm turning this over to my colleague from the American Society of Health System Pharmacists, Anna Dopp.
Thank you, Anne. Well, this next session will have great synergy from the last. My name is Anna Legard-Dopp. I'm the Senior Director of Clinical Guidelines and Quality Improvement at the American Society of Health System Pharmacists. Session 3 is focused on hybrid pain and SUD care delivery across care settings. This session recognizes that those patients that require pain management and those patients that require OUD and SUD care experience care both episodically and longitudinally across the continuum of care. So for the next 35 minutes, we're going to forego slide presentations and just dive into the moderated discussion. Our panelists will be introduced in just a minute, but they will be charged with talking about 3 key topics and then seeing where the conversation goes after that. The first topic will be to have an opportunity to talk about this co-creation idea that Dr. Burson charged us with earlier as our meeting started. But what is the future of hybrid care delivery for both pain management and SUD care look like across different care settings? We'll discuss the aspects of pain management and SUD care, which aspects are best suited for the virtual care environment and which ones really should be done and require in-person care. And then lastly, to explore the impact of the variance in health systems and or patient care plans and how that might impact the delivery of hybrid pain and SUD care, and how do we get past the barriers and expand into that opportunity for future action. We have 4 panelists with us today. I'll go in order. Dr. Elizabeth Bentley, who we just heard from a moment ago, is a clinical pharmacist and the director of inpatient pharmacy at Kaiser Permanente Northwest. She is also one of the planning members for this telehealth and virtual care series that we're in meeting 3 right now. Dr. Ben Nordstrom is an addiction psychiatrist and the chief medical officer at Behavioral Health Group, which is the largest network of Joint Commission accredited outpatient opioid treatment and recovery centers in the United States. Dr. Lewis Nelson is a board certified physician in emergency medicine, medical toxicology, and addiction medicine, who currently serves as chief of service of the University Hospital Emergency Department at Rutgers, New Jersey Medical School. And last, but certainly not least, Dr. Ada Stewart is a family physician and board chair of the American Academy of Family Physicians, which represents more than 127,000 physicians and medical students nationwide. So if I can invite all of you to be off camera. And as your introductory comments about yourself and your practice setting, we'd like to have a discussion about how you've been using telehealth and other virtual care services. And then if you can weave in there how the pandemic has impacted that, and then what changes would you like to keep and which ones you feel were best. So we'll start with Dr. Bentley, and then we'll go to Dr. Nordstrom, Dr. Nelson, and Dr. Stewart for this conversation.
All right, well, thank you so much for that introduction, and happy to talk about our model and particularly how it fared over the course of the pandemic. We really have had our telehealth model in place for many years, more than a decade. Specifically, we have one that's focused more on pain management and opioid use disorder management, which includes tapering, but also optimizing pain management, as well as looking for therapeutic alternatives, providing supportive care. And really the cornerstone of that is utilizing the relationship that the patient already has with their primary care physician and becoming a part of that care team. So the way our model works is really that physician has an initial conversation with the patient about their goals and treatment. And that would include quality of life goals, pain management goals, if they're desiring to taper off, et cetera. And then once they've had that conversation with their provider, that is when they would be referred to our team for management. And as I mentioned briefly earlier, that is done by a social worker who has an initial conversation with the patient around what to expect, really make sure to take a patient-centered approach to understanding their goals of therapy and what success means to them. So, we may have a preconceived idea that success is being on a lower dose or tapering off. To them, the most important thing might be being able to play with their grandchildren, to be more present, to have their life more what they would consider having their life back, that sort of thing. So making sure that we're all in alignment on those individualized goals. And that's really where our pharmacists take over and work with the patient on an individualized basis. And this can be brief. It could take a few weeks. It could go on for months. We've had some patients even for several years due to the complexities of this process and the need for ongoing referral. So, and I do want to hit home on a point that was mentioned earlier, that sometimes the old-fashioned way is the best way. So we do most of this via telephone, and certainly have other options, but for the pharmacist piece, we do leverage telephone primarily. And this is all connected back with their physician and their ongoing care. So everyone is aware of the patient's progress, goals, any setbacks, and also, as was mentioned earlier, there's that gray area around, what is dependence, what is pain management, and where does that intersect? We're often finding ourselves walking that line and referring to other teams as well. So that's our primary team that I'm going to focus on for this. You had also asked Anna about some of the unexpected benefits and drawbacks that we uncovered during the pandemic. Our team is also involved with virtual pain management sessions. And at first we had thought, not having this connection in person is going to be highly detrimental to these patients. They're really relying on that connection. What we then found, somewhat surprisingly, was there were also opportunities for patients who lived in more remote areas to have that opportunity to connect virtually over those virtual group sessions. I think maybe counterintuitively, another benefit was that we were better able to sympathize or empathize with the position of our patients in dealing with the isolation during the pandemic, really feeling that ourselves as well. A couple of the key barriers, not surprisingly, some people had lack of internet access, so that was definitely detrimental. And then another issue was a lot of our alternative methods for pain management. Say if someone had a preference for, they like to get a massage or go swimming or that sort of thing, a lot of those options were not available. So having to rethink our options.
Thank you for that. Dr. Nordstrom, we'll turn it over to you for your comments, please.
Sure. Thank you so much. And I appreciate the opportunity to talk with everybody. For our company, the pandemic was really the big forcing function to have to get competent with teleservices. We've got about 40,000 patients in care on any one day. And then suddenly with the start of the pandemic, we had to stop having people come into the clinics on a daily basis. And we really had to make a lot of changes. So there was a very, very swift shift to using telecounseling services. Like Dr. Bentley noted, most of that happened over the telephone. We have a lot of indigent patients who don't have smartphones, and if they do have smartphones, they don't have a data plan that would support something like a Zoom chat or any of the rest of that. So a lot of the counseling was just done telephonically. The other big thing that changed for us was we shifted. We couldn't have groups because we couldn't have all those people in the same room for that amount of time. And so we started doing more tele-enabled groups as well, and even had been running tele-enabled IOPs or intensive outpatient programs through the pandemic as well. Kind of the third big bucket that where we had to get good with tele was on provider visits. That there has to be a face-to-face encounter with a physician for a patient coming into an OTP, and we could do that. We could accomplish a face-to-face. Having a provider in one site just tele in for the patient. And sometimes they were in the same building, just in different rooms. And we could use tele that way. There are three big, I think, benefits and things that we want to see kept from this is that the telecounseling is actually something that's worked out very well for some of our patients. Now, some of our patients wanted to go right back to in-person as soon as they could, but a number of counselors told me that they had some patients who found that distance, not being in the same room with somebody, actually allowed them to open up more. It's almost like being in a confessional booth, that it was just easier for them to get talking and stay talking. It's also for some counselors, they appreciate being able to use tele because a lot of our clinics open at like 5 in the morning, 5:30 in the morning. And so it allows for more flexibility just in the time of the Great Resignation, that we can have some flexible work hours for counselors and they can call people at different points in the day and do counseling that way. So that's been beneficial. When it comes to things like tele-IOP, we operate in some very rural areas, very remote areas. And a lot of our patients don't have reliable vehicles. And even if they have reliable vehicles, the roads aren't reliable because of weather and things like that. And so, we want to use the idea of tele-IOPs as a way of being able to deliver that service to people without having to have all the kind of ancillary inconvenience that comes with it. And then lastly, we've really embraced using teleproviders. And really being able to leverage one person across multiple sites in order to just improve network access, decrease wait times and things like that. So, I mean, all in all, I don't know if we would have had the guts to dive into tele as much as we had to because of the pandemic, but I think that it's brought a lot of very valuable lessons for us.
That's a positive note to end on with those comments. Thank you. We'll transition to Dr. Nelson to provide the perspective from the emergency department.
Yep. Thank you, and thanks for having me. It's very interesting so far. So we started a telehealth program involving acute evaluation of patients about 5 or 6 years ago, mostly through contracted work with several industries in the area. I live in northern and work in northern New Jersey, a pretty densely populated area with a fair amount of industry. So we had been providing some sort of what you might call urgent care for that population. Some of it involved viral illnesses and things, but a fair amount of it involved minor occupational injuries, which allowed us to do evaluations of patients via a telehealth platform. We struggled a little bit with some of the platform issues and actually getting it to work in an effective fashion. But of course, when COVID hit, we had to change a lot of our efforts because many of those visits did have to become virtual. And we also at the same time started to segue a lot of our addiction work over into the telehealth platform, as has already been discussed. I don't really want to restate what everybody's already stated. We were able to do evaluations for most people most patients over a telehealth platform. Often it did result in an ED visit because some of these patients were just not evaluable easily. They required actual physical in-person examination. Some required x-rays. We did have a link to get x-rays on an outpatient basis, but it was never as easy as you'd like it to be. Somebody had mentioned earlier about trying to coordinate all of these things. It's quite complicated to coordinate a lot of moving parts. But when it worked very nicely, but in many cases, it just turned into sort of an entree into the emergency department. You were partially evaluated before you even got here, and then we would pick up the ball and run with it when you got to the ED. We did have already a buprenorphine initiation program in place in the emergency department with a nice solid handoff to the post-care clinics, the treatment programs that we sponsored at the hospital and in some of the outpatient areas. But when we really had to turn in earnest to the telehealth platform for addiction management, early on we made it mostly again, the demographic of patients we work with is largely, undereducated and marginalized, not with not very good access to internet and phones. And we had a program to give out smartphones to a fair percentage of the population we were treating, but even then, they would lose them and break them and sell them, and there were all sorts of problems getting the program to sort of be consistent and sustainable. So we had actually an in-person component to the telehealth visit. So we had a telehealth station set up in the lobby, and we were able to accommodate patients to come in and do that. So there were no face-to-face visits, although the site was often local to where we were. That ultimately transitioned over time as the pandemic worsened, and telehealth sort of opened up some of the allowable activities. And much of it was telephonic as well, and not even done for the limitations stated and for the reasons others have stated as well. So that's where we largely are today. And we have sustained, like has been mentioned, a large part of our outpatient management sessions and prescribing have been done through telehealth, and we've kept that going.
Thank you. And for a very important piece of the care continuum, Dr. Stewart, love to hear your perspective.
Yes, thank you so very much. And thank you for allowing me and the voices of family physicians to be heard today. Family physicians, we care for the full spectrum of individuals. We provide longitudinal and comprehensive acute care, chronic care, care for individuals with for chronic pain management, also substance use disorders. So we do it all. And prior to the pandemic, about 15% of family physicians all over the country actually use some form of telemedicine. During the pandemic, because we saw the impact of patients not being able to be seen within our practices, they did not come to the offices. We really were able to pivot on a dime and incorporate telemedicine. And about 99% of us used some form of telemedicine. Issues that we were having were, number one is being able to be reimbursed, having payment parity, regulatory issues as far as CMS and things such as that were huge barriers to many of us. But because of the pandemic, we were able to alleviate those barriers, and we have seen the success of telemedicine in providing access to our patients. It has given us a way to really see another tool as far as being able to provide that longitudinal comprehensive care to individuals. I have a large amount of patients who have transportation issues. It has really solved that issue, not having to travel to my office to be able to see me. Telehealth has really provided us so many, I would say, it's alleviated many of the barriers that we had in providing access to our patients. And, as others have already mentioned, we do have many barriers that have also been elevated during this time, such as the pandemic. And those include, issues with broadband. What we would like to see moving forward definitely is ensuring that there's some form of payment for or audio only. Many of my patients can't use they don't have smartphones, or if they do, they can't use them. Visits that begin with video end up being phone because of issues such as usage. And as we talk about digital divide and literacy as far as digital technology is concerned, these are very much real barriers. But again, recognizing how important telemedicine has been to providing care to all our patients, and making sure that we continue to promote its use, and making sure that we realize that this is just one other tool for us to ensure equitable care and access to all our patients.
Well, thank you for that great discussion from all of you, and important things to be thinking about. Well, and I want to remind people, participants that are listening, to please provide questions or comments in the chat. And then we'll go back the other way around with the next question. So going back with you, Dr. Stewart, make you tire out your unmute muscles again. But given the high patient volume that you were just speaking to, have you looked at what aspect of pain management or SUD care that you feel would be best suited for virtual care versus in person? And have you stratified maybe the patients requiring pain management need something versus those with SUD?
Yes, so thank you for that question. It's really important that we recognize how there are some limitations, especially when I look at my patients who I'm trying to provide pain management for. Not having that ability to touch that patient, not having the ability to access whether the treatment plan that I have, that we have together formed, is actually working, seeing how their mobility, how well they're able to, function, what their functional status is at that time. We have some limitations as far as telemedicine is concerned in that. I have been using the telehealth platform for my patients more so for that check-in for pain management, to actually have those conversations to see where they are, how they're doing. Again, for individuals who are pretty much stable, it's been much easier. For individuals who are, new, who I'm trying to, really establish care with, it's been a little bit more difficult because we have within my particular state certain criteria, such as making sure that we do urine drug screens periodically, and getting that information from a patient via a virtual platform is a little bit more difficult. Even getting like urine cups to patients is a little bit difficult for me, for my rural patients. Their mail is a little bit different as far as accessing that, and so there's a lot of things that I am limited on in caring for that particular patient. When I look at substance use disorders and being able to use the telehealth platform, it's been a little bit easier, especially during this pandemic. Some of the limitations that we had prior to the pandemic were alleviated as far as patients being able to receive medication, longer use of medications, 30, 60, 90 days. That's been kind of limited. And so we have had some advances because of the pandemic, and hopefully these will continue, because again, it's an access issue. It's making sure that we can provide high quality care to our patients in whatever platform that we use.
Thank you, Dr. Stewart. Dr. Nelson, how about you?
Yeah, I have, in the acute care setting, things are a little bit different. So I appreciate Dr. Stewart's comments. When you have an established relationship with a patient, it's a lot easier to make some of those determinations. So we when we transitioned from this contracted model with industry to much more of an open model, where we took all comers, we were fairly loath to prescribe opioid pain medications virtually into a patient population we didn't know. So many people who were in severe enough pain with acute pain to require an opioid would pretty much be expected to come to have an in-person visit in the emergency department. Obviously, prescribing non-opioids wasn't really a concern that most of us had, as long as we were able to provide, convince ourselves sufficiently that the patient didn't need an in-person evaluation, and that's for acute care. We really did not manage chronic pain patients over the telehealth platform. It was just far too difficult. It's hard to manage the population in person. It's hard to manage the population when you know the patient. It's very hard in sort of an undifferentiated population that we're dealing with to try to do those sorts of things. So we really just referred those people either to come in and we'd see them, or to refer them back to their primary care or pain management, pain medicine physician. It just did not work very well. But the platform itself for managing pain worked fairly well. I mean, you remember, most people who have significant injuries are not going to access a telehealth platform. They're going to come in. And most chronic pain patients tend to avoid the emergency department for a lot of reasons, which, I'm sure everybody on the call is aware of already. When it came to the patients who we were managing with substance use through the addiction medicine clinic or the addiction clinic, we were really, even though we work in an urban setting, not a rural setting, our patients have a lot of challenges getting in as well. And I think we very quickly transitioned to a situation where very, very rarely did patients who did not want an in-person visit were they required to have an in-person visit. Some people, as has been mentioned, preferred still to come in and get seen in person, and we were able to open that back up. We were able to do that, but in general, we were pretty able to manage most patients without any in-person visit. We were able to get urine toxicologies done through outpatient settings, just like we're able to get x-rays done and things like that through outpatient settings.
Thank you. Dr. Nordstrom, how about from the perspective of the behavioral health group?
Sure. So, there's kind of two broad classes that I think have really kind of leaned into the teleservices from a patient perspective, at least for just straight counseling. The first would be very stable patients. So patients who are in a stable remission from their substance use disorder, they're doing well. We have an existing relationship with them. That seems to be the kind of thing where they actually prefer going to shorter telephonic kind of conversations, or more like recovery check-ins. They're not in the acute phase of treatment. We're not delivering an evidence-based treatment so much as we are just keeping a channel of communication open. The second class of patients, I think the people who are in our harm reduction pathway, people who are not really interested in accessing kind of a full suite of services to get into recovery, but they're just looking to either reduce or eliminate their opioid use, but don't really want to address other drugs and things like that. They don't want to do counseling. We don't insist on it. We want our main focus there is retention and just kind of keeping them on the medication so we can reduce their chance of overdose death. And so sometimes those touch points are kind of catch as catch can. Sometimes they're conversations in the parking lot. Sometimes they're, if we can just get them to pick up the phone and talk for a couple minutes, that's really useful. In terms of the broader the broader things, again, I think, we're really looking at our remote areas, places like Eastern Kentucky, places like Northern Michigan, that we want to be able to use tele-IOP services just to kind of ease the transportation concerns of people in those areas.
Thank you. Dr. Bentley with Kaiser Permanente, please.
Yeah, I think something else to hit on in terms of differentiating when one type of outreach might be preferable. When we're talking more about monitoring and management, I think that's when brief outreaches can be very helpful. So another service that we do provide is we do some monitoring for our patients, whether it's for pain or for other medications that they're using for OUD, for example, really to make sure that they're getting their regular visits, that they're doing their required screening, looking for any early flags that there might be concerns or they might be having difficulty with their plan. A lot of that can be done behind the scenes with brief outreaches, and it's very effective from a pharmacy perspective. I did also want to emphasize as well, our team that does the more complex tapers and treatment plan goals, those can actually work well as a longer visit over the telephone. It's kind of surprising how quickly those relationships can form. And I've even interviewed some of the patients later, and they'll say, well, it was really nice to meet them. I never knew what they looked like, but I feel like they were my best friend, you know? So it's amazing how you can leverage that in different ways. But yeah, I think for the monitoring piece, it's very effective.
Well, hearing from all of you is that any attempt to operationalize or standardize really is a meet the patients where they are mentality first. I think is a very common theme from all of you, which takes a lot of effort, definitely. Dr. Nordstrom, we'll circle back to you and have you kick off the next discussion. And some of this has come out already, but in terms of scaling up or trying to go where you want to go, what are some of the barriers that we need to work collectively to try to advance the goals that you have?
Well, one certainly kind of just is on the regulatory side and making sure that nothing that we do, we operate in a highly regulated space, at least for our opioid treatment programs, and making sure that that our state opioid treatment authorities are always on board with what we're doing and making sure that they're comfortable with it. Making sure that the payers are comfortable with it. It was one of the challenges we had, was making sure that on the revenue cycle management piece, we were capturing the detail around which sessions are telephonic. And now that we're going back to a blend of inpatient and still some telephonic sessions, just making sure that that's all being kind of correctly captured. I think the challenge that is when it comes to equity is, I think one that's come up several times, is just not all of our patients have the same access to use teleservices as robustly as others, and it's just something that we need to be mindful of. And I think that the more that we could do to reduce the inequities in the system in terms of who can really make use of tech, I think that over the longer term, that's going to be an important hill for us to climb.
Thank you. Well, let's go to Dr. Stewart next, and then we'll go to Dr. Bentley and then back to Dr. Nelson.
Awesome. So definitely agree with regulatory issues, making sure we address those. The other is payment parity, especially because so many practices end up having to get equipment and change their practice settings to be able to accommodate and to use telemedicine. So we have to ensure that that continues to exist. Address the barriers such as the digital divide and as previously mentioned, equity. We do have to, as you mentioned, meet our patients where they are, and that includes ensuring that there is payment for telephone only services, because many of our patients don't have access or the ability to be able to use audio only. And then, of course, addressing issues within practices. Staffing issues are pretty much a concern. Many thought that when you went to telehealth, that staffing issues would be alleviated, but many of us have seen that it's even more of an issue. We have to help our patients be able to access the platforms that we're using. It just takes a lot of staffing work and ensuring that those issues are being addressed. So those are some of the very important issues that I think we need to really accelerate as we move towards this new method of being able to care for our patients.
Thank you, Dr. Bentley.
Yeah, and what's been said so far really resonates when I hit home on the point around having multiple modalities available. I think even though we do provide care in different modalities, it's often served up as one flavor for one type of issue. And maybe thinking about more, how can we meet our patients where they are, like Sven said, and then also payment and addressing any regulatory barriers. All of those are really critical.
Thank you, Dr. Nelson.
So we had a little bit of trouble getting our telehealth platform up and running for a lot of sort of technical reasons, and actually implementing it has been challenging because of even my institution, we have several different EHRs that we use. And often the telehealth platforms are not agnostic to the EHR. Some are actually based in the EHR, which makes it somewhat challenging to sort of communicate across different platforms. We've had some trouble trying to integrate, for example, the prescription monitoring program into our workflow. And it's taken a lot of effort from a lot of smart techie people to get those things to interface with one another. And every state's different, every institution is different, and the number of permutations that you have to figure out how to make work is so challenging. Our e-prescribing has been difficult too. We have the state I live in or work in, we have to prescribe directly to a given pharmacy. That doesn't always work. And it's hard enough when the patient's there with you. It's even harder when they're on a teleplatform and then they can't get back to you when there's a problem, right? At least when they're there with you, you can communicate directly with them, as opposed to, say, a cloud-based prescribing system where it can be picked up by the pharmacy. We direct it to again. So there's a lot of those technical hurdles that have to be overcome in order to get it to work. That's for pain. It's a little easier in the addiction side, where we have a standing relation with a patient. We have access to the patient. It's a fairly predictable pattern. But on the pain side of things, at least, it has been very difficult to get it up and running. Well, we've hit our stride, and then we run into staffing issues, which has been very difficult. Getting it, for example, we use Epic, getting the MyChart connection. And getting people to sign up for MyChart, getting MyChart to schedule appointments, or getting the system to schedule appointments. These are all, choke points for the system. And until they're up and running smooth, it's taken the better part of a couple of years to get them to run independently and well. And I hate to say it, it still doesn't.
Well, you raised a really good point, and just doing a time check here, we have 5 minutes left. And what you just mentioned, Dr. Nelson, does build off of a question that Dr. Burston had earlier about how do we make sure that the information flows and that there's coordination between all these points. So for our last 5 minutes, and Dr. Nelson, we'll let you start because you haven't gone first yet. And then we'll go to Dr. Bentley, Dr. Stewart, and Dr. Nordstrom to talk about that coordination, flowing of information, but then also anything else that you want to add in your last few comments.
Yeah, given the time, I'll be brief. And I said a lot already about the coordination. It does, it is a problem with all of our electronic communication, and it is all electronic communication. I mean, it's what we ultimately have to wind up doing when we're dealing with all things telehealth. And we recognize that, Apple's and Windows computers talk to each other now, so it's possible to get these things to work. But somehow, Epic and Cerner and all these other companies just can't seem to communicate very well. And then there's 10 other EHRs you probably never even heard of, and they all have to communicate with one another, along with every state's infrastructure and regulations and everything. It's challenging. I work in an area where it's pretty dense with other states. I mean, we see people from New York and Pennsylvania, Connecticut, where I am, and it's even harder when you're dealing with cross-state communication. So a lot of these things have to be perfected. I don't know how to make it happen. I wish I did. A lot of it's going to be legislative, regulatory, rulemaking, things like that. It's doable. I mean, if they want to put their mind to it, they will be able to get it done. But somebody's going to have to sit down and make it happen. It's not going to happen organically. I don't think. There's just too many variables here.
Right, thank you. And with 1 minute each, next we'll go to Dr. Bentley.
I can be very brief here, and I certainly don't have the solution to this issue. I think as an organization, we're at a distinct advantage here in that we're an integrated model. So most of our care is occurring internally, and we can see care on the inpatient side seamlessly with what's going on in the ambulatory space. And we do leverage our content to alert providers. So say someone's admitted, they're going to know what their care plan is and who's managing it. So I really wish that we had more of that across the country and had that seamless model. And again, I don't have a perfect solution. It's such a big issue.
Dr. Stewart.
Just piggybacking real quick, we truly have to advocate for a regulatory and ways for us to be able to have this integration throughout all our systems. It's really sad that we have such fragmentation, and it hurts our patients. And so hopefully we'll be able to address this, and we just have to continue to do what we're doing and advocate on behalf of our patients and our specialties.
I can go really fast. I amen to everything Dr. Stewart just said. That's it.
Well, you just caught us back up on time, and just want to say that it's a good challenge to end this discussion on, and something to try to build towards in the future. I want to thank all of our panelists again for sharing your time and your expertise, and also to the co-chairs for helping to organize this event, and of course to the NAM staff for making it run so smoothly. So with that, we have just over 10 minutes for a break, joining again at 3:50 for session 4.
Thank you.
Hello, Helen. I figure I would mic check myself before we fully kick things off.
Hey, Matt, good to see you.
Likewise.
All right, we're going to give it 1 minute and we'll start. All right, I'd like to welcome all of you back with us for our final session today. Thank you for hanging in with us. For those of you who've been with us for the last 3 hours, it has been, I think, just an extraordinary conversation. I've learned a lot about what's possible. And I think what you're going to hear in this session is really a broad view of really thinking about what are those opportunities for integrated hybrid care. I think we're going to start broadly, thinking about telehealth broadly, and then hone in a bit specifically on pain and SUD, but really thinking about how a variety of different players, including payers and purchasers, clinicians, really think about what opportunities this could be. So we're going to have for this session 3 great presentations. And then just to give you a sense of it, hold your questions until we get to the discussion format, which I didn't do in session 1. So don't follow my example. I was just so excited to ask a question. After the first presentation, we'll, just please put your information in the chat. I'll come to you at the end of the final presentation. We'll have a good amount of time for questions and sort of summative comments. So please continuing to do that. Feel free to raise your hand as well. We'll wrap up about 4:50 or so and allow us for a final bit of comments before we end. So we're excited to have the first 2 sessions that'll be back to back. And then we'll have a little discussion, and then the second one will be about 10 minutes. So why don't we just go ahead and get started? I'm delighted that our first speaker today is Dr. Will Lopez, who is the National Medical Director for Virtual Care at Evernorth, which Cigna launched to accelerate the delivery of innovative, flexible solutions to meet the diverse needs of plans, employers, and government organizations. He'll be followed by co-presenters, Matt Sakamoto for the virtual first primary care doc who funnily at Sutter Health, who I know sort of well in this very virtual world of working together on our telemed tweet chats, and Lindsay Baran, who is the policy director of the National Council on Independent Living, where she started and co-chairs their chronic pain and opioid task force. She's also a member of the National Pain Advocacy Science and Policy Advisory Council, but really, I think in many ways, most importantly, Lindsay represents those with lived experience as someone who lives with chronic pain for most of her life. So with that, I'm going to turn it over to Will to get us started on key considerations for the future of hybrid care delivery to improve pain and SUD outcomes. Dr. Lopez, over to you.
Thank you, Helen, and thank you all for having me here today. I really appreciate this opportunity. So we can jump to the first slide. Anyway, so talking about from a payer's perspective, and let me just put that in perspective, that I'm just talking about Cigna's and Evernorth's positions, so this may not apply to all payers across the board, but at least will give you a little insight into how some payers think about the opportunities that we now have thanks to virtual care. So from the perspective of treatment of substance abuse and back pain or chronic pain, let me first start addressing the pain management issues. And then at the end, I'm going to wrap it up with a few comments on substance abuse. And I know that Helen's going to keep me on the clock, so I'm going to move along fast here. So anyway, the most of the advantages that we have experienced and that we're looking for with virtual care had to relate with increasing access and convenience for our customers. We're having the ability to increase compliance because the customers have another entry point to services for physical therapy, especially when we're talking about chronic pain or pain management or some other conditions. Many times the customers don't go for treatment because lack of time, work schedules, conflicts. And this helps break that barrier and simplify access for them. Another advantage that we see is that we can really provide, or our providers can offer integrated care, holistic care that include not just medication for pain management, but also cognitive behavioral therapies, and other behavioral modalities that we know help in the management of chronic pain. We see better outcomes because when you have a customer or patient that goes to the physician and they get a piece of paper saying, here, do these exercises. For one, they may not understand or do it right at home. And the second piece of that is that they may not have the time or the accountability to do them appropriately or the amount of time that is required. And ultimately, if we do everything right for our customers, this is going to impact the cost of care. We believe, and we have seen in some of our programs, that we can have great outcomes with decreased cost, total medical cost. Let's jump to the next slide. And what are the barriers that we're seeing advancing hybrid care models? Many times it comes down to finding the right partner, someone that is willing to take steps toward a value-based relationship, and that also offer a broad spectrum of services, like I mentioned before, physical therapy, but also cognitive behavioral therapy and other coaching modalities to help with better outcomes. In addition to that, another challenge is just engagement by the customers. And as you can see, that's one of the big challenges for many providers as well. The patient may not feel that they're going to be successful, they're discouraged because of the pain they're experiencing and other reasons. But also another barrier that I will mention and will echo some of the comments by other presenters earlier today, including Dr. Stewart, is regulatory requirements. One of the challenges that we see is regulatory inconsistency across state lines, and from what type of provider can offer virtual to what modalities are covered, telephonic or not. So having regulatory consistency across the board would go a long way in facilitating hybrid models and other ways of delivering care virtually. Next slide. And what are we doing as a payer to innovate and help promote hybrid models of care? One example that I can offer to the group today is our relationship with Recovery One, which is a digital physical therapy program that provides PT solutions that are delivered through your iPad, smartphone, and across, they're a national vendor, so this is across all states, and that supplement the brick and mortar providers. Like the example I was sharing before, you go to your provider, you get your piece of paper. Now the provider can say, hey, you get this paper. Also, we're going to connect you to this provider group, Recovery One, who has coaches and PT specialists that can help make sure that the patient is doing exercise correctly at home and has the most benefit out of their therapy. Cigna is also engaging in Evernorth, I should say, both Cigna and Evernorth, engaging in developing an end-to-end MSK model to help patients with chronic pain navigate through the healthcare system. And this will be for back pain or knee or hip pain related to arthritis. And it will be providing a navigator that will help them with appointments, with accountability, connecting them to coaching programs. And currently, this is in pilot in the state of Colorado. So no, I don't have much details, but I just want to give you a sense of where we're moving. Another area that is not necessarily related to innovation, but that's really going to help drive innovation is reimbursement. And Cigna has taken some steps to make sure that we reimburse for physical therapy services and for rehabilitation services. We included a number of CPT codes in our virtual coverage policy that are directly related to physical therapy and occupational therapy. And we did this in collaboration with these different organizations, including the American Specialty Health Group. In addition to that, just this year, CMS rolled out a new set of codes that are called the Remote Therapeutic Monitoring Codes that are specifically targeting MSK and one more condition, respiratory. So those conditions, and helps patients self-report symptoms to their providers on a regular basis and actually kind of complement some of the solutions that were mentioned before related to remote patient monitoring. So this is a great opportunity to innovate as well. All right, I got a time call here, so let's move along. Next slide. What are we doing? Basically what we want to do is develop value-based relationships. We want to do this based on outcome data, like HITA scores, and having some other metrics like utilization, decrease of higher level utilization of higher levels of care, and other measures that may help show that the treatments are effective and that we're helping our customers. Last slide. So what about substance abuse? We also have a lot of work around substance abuse, and we do favor them because of the same reasons as with pain management, especially with compliance and actually privacy. Some of the barriers, again, relate to finding the correct provider that have a broad spectrum of services virtually, and also the regulatory issues. When it comes down to some innovation, we have developed a number of relationships with different groups. Virtual, they are totally virtual or a combination of virtual. Some of them are listed here. Some of them provide opioid treatment, both counseling and dispensing medication, and other ways. Others, like MAP, also provide peer support, which has been shown to be effective in the treatment of opioid dependence, use disorder. And then some of the strategies that we're looking at are the same. We are in a number of value-based relationships right now with substance use disorder provider groups across the nation that are able to demonstrate great outcomes related to decreased readmissions, decreased use of higher levels of care, better outcomes with other indicators that I can expand during the Q&A session. And I think that I may have covered right on time. So I'll leave it at that.
That was perfect, right within your 5 minutes. Thank you so much. And we'll have a good opportunity for discussion after our next session. And we're really excited that Matt and Lindsay are actually going to serve as co-presenters as they talk about co-designing these new systems of care delivery. Turn it over to you guys.
Perfect. Thanks, Helen. I guess we can both introduce ourselves. So Matt Sakamoto, Helen did our intro. I guess, Lindsay, if you want to say a quick hi as well.
Sure. Hi there, Lindsay Barron. I'll say more later.
Perfect. And like I said, I'm super excited about kind of talking about this idea of co-design and really looking forward to new systems of care delivery. So we spoke a lot about where we are, kind of the challenges that we're facing. We'll highlight those and actually kind of think about how to build on that. Next slide, please. So the roadmap, current state, we talked about that at length, so I'll go through that pretty quickly. Speed bumps, and again, what are the barriers that we're facing? And then lastly, that co-design piece, and we're going to spend at least most of a chunk of our presentation time talking through that. Next slide. And so current state of telehealth. Next slide, and I'll kick it off to Lindsay.
Great, thanks so much. All right, so pretty quickly after COVID began and the need for social distancing in all areas of our lives began, we saw a rapid increase in the use of telehealth. The fast expansion was obviously critical, but largely because of the urgency with which it was done. In a lot of places, it was done somewhat haphazardly. So systems were built out of existing platforms or new ones were put quickly in place with the practical thinking of meeting a very real and timely need, but not necessarily to be lasting systems that worked best for everyone, and definitely not necessarily with the forethought of what we would want to do with the future of virtual care. Telehealth 1.0, which is how we're referring to it here, has helped to enable basic care delivery during the pandemic, and it's presented both opportunities and barriers to maintaining the therapeutic relationship, which Matt will talk about a little bit more later. And as we look ahead toward how we can improve that and the evolving nature of care provision, we also want to take a look at how we can continue to build on Telehealth 1.0 toward the future of virtual care broadly. And we have to do that in the context of where we are now with the specific public health policy, emergency policy considerations, both the ways in which flexibilities have pushed telehealth forward and the questions that come with their unwinding when the public health emergency ends. So we can move to the next slide. So let's first talk about some of the speed bumps we've run into, and we can go to the next slide. Thanks. So we won't spend too much time focusing on the barriers, but they're important to address. Like we talked about, this rapid shift hasn't allowed for a focus on the users and has resulted in people being left behind and inequities being exacerbated. I know this has been mentioned previously today, but we know how many people have unreliable access to the internet or to devices. And these people have either been left out of this advancement altogether or largely rely on audio-only telehealth for their care. And so it's unclear whether the flexibilities around that coverage will continue. People with disabilities have faced significant barriers as well. So for just a few examples, telehealth systems might not be compatible with things like screen reading software for blind folks. Deaf and hard of hearing people have had problems with video interpretation and captioning. I'm hard of hearing, and earlier today, the Zoom auto captions on several meetings I had today weren't working. So even just malfunctioning, things like that with technologies can be a barrier for folks. And then people with other disabilities, particularly cognitive disabilities, have faced barriers with systems that are more complex and not user-friendly, especially if there aren't opportunities to prep or guidance isn't available ahead of time. So telehealth has definitely increased access for some disabled people, but new barriers have arisen for others. And then folks with pain and substance use disorders face barriers as well. So even though some of the requirements around e-prescribing and e-prescribing controlled substances were relaxed, some states and insurers and practices have conflicting practices. And so the flexibility didn't apply equally to all pain and SUD patients. We know there were people with pain or SUD who use opioids or opioid agonist treatment who were required to continue going in person throughout the pandemic rather than be treated by telehealth, despite the federal policy. That's just one example, but I'm going to speed up briefly just to talk about the policy really quickly, because we obviously saw a lot of changes to make telehealth more widely available. Just a few of those are we saw the waiving of requirements so providers can deliver telemedicine across state lines. We saw the established patient requirement not be enforced. As I mentioned before, the DEA loosened requirements on e-prescribing of controlled substances, and we saw a lot of insurers broaden coverage for telehealth and reduce or eliminate cost sharing. A big question, though, is whether that access will be preserved as states' emergency declarations wind down. We're already seeing some people lose access. And then also when the federal PHE ends. And I think an important barrier here is also that, we're continuing to deal with a patchwork system of conflicting federal, state, local, and then insurer policies as well. And that may continue to get more complicated as the PHE winds down and the new policies are enacted. So it's kind of a moving target with layers of complexity that we just have to keep our eye on. I'm going to turn it over to Matt because I think he might have more on this slide, and then we'll move on.
No, I think you covered it very well. And again, we talked about this at length kind of throughout the earlier talks today. I think not a whole lot for me to add on my end. So we can go to the next slide. And this is kind of the meat of what we're chatting through. So we talked through why are we here, where are we at now, and a lot of the chaos of sorts that we're sitting in. But I think two main things that we can hopefully use as guiding pieces as we start to untangle the new normal with virtual care are two concepts: digital empathy and co-design. I won't read out each of those definitions, but I think that's kind of my guiding light of sorts as I think through how should we build this. And it's very much patient first through both of these. So digital empathy, really, how do you be empathetic just person to person? But I think in particular, as we've seen, communicating through Zoom and also actually text-based communication, very, very different. I do a lot of virtual care, and the language that we use, words matter, delivery matters, punctuation matters. So all these little things that you don't really think about actually get multiplied. And that's kind of the piece that we think about for digital empathy. And the other half of that is, how do you empathize with patients and how do you co-design with patients? So again, there's a patchwork of policy and protocols and practice patterns. But I think one piece that has been sorely missing is the co-design with the patient. So really getting the patient voice in there up at the front. And we can kind of get ahead of this now. So I think that co-design piece is important rather than having to go back and retcon a lot of the current designs that were kind of put in place hastily. But then again, kind of getting a patient voice and all patient voices, so making sure that it works for the majority of our patients. Next slide. And so let's talk specifically about the co-designing piece. We can go to the next slide. So co-designing the ideal visit, actually, I'll kick it over to Lindsay and kind of her thoughts on this.
Yeah, so we were talking about kind of the importance of involving, the end users, kind of all of the users in the development and the design and even the conceptualizing of these systems. And when Matt and I were talking about co-design, it brought up for me an idea we talk about a lot in the disability community, which is the concept of retrofitting accessibility. Basically taking something that's fully designed and then going back and fitting in accessibility for disabled folks after. So we're talking about, if you build a building and then you fund later a costly construction project to put in an elevator and ramps and things like that. And so, taking this same concept that we talk about a lot in the disability community and applying it here where we have these systems that we have the opportunity now to expand significantly to make work for all of the people who are going to be involved, the clinicians, the administrators, the patients, all of the people who need access, as we're talking about what we want to see in the future of virtual care. I think we all want to see it expanded from what it is now. And so we want to make sure that everybody who's going to be a part of it is a part of that kind of development. And I think, Matt, you talk about this a lot more than me, so you probably have more to say, but this really resonated with me when we were having these conversations.
No, for sure. And I think we want to get this concept out there and definitely want to do some deep dives in our discussion afterwards. But yes, it's really the co-design piece is get the patient involved and the patient voice involved, and actually I'll reiterate, not just the PFAC or kind of like patient family advisory council, actually try to find some real patients. I think that's the other piece too, is a lot of times the advisory councils are great, but they sort of are a area of convenience. So anyway, look beyond the PFACs as well, is the other piece that I'd say when you're co-designing. Next slide. This is a fun slide for me. So I think it really, and this slide, I was very happy when Helen reached out for me to present, for us to present, because it really says what can we do beyond just the video visits. So video visits are kind of there in the middle of the screen, but really the asynchronous bit, so the far left, so texting alerts, chat and chatbot, some of the store and forward pieces. This opens up a lot of, I think, connectivity, especially if you are keeping the digital divide in mind, just because it actually multiplies clinician time as well as really opens up access for patients. And then, so we'll kind of highlight three green pasture areas where we hope this can kind of take us in the future. So text-based things, chat-based things, and then the group visit kind of there on the far right, which I think we can leverage technology rather than have to, like we said before, retcon technology. Next slide, please. So through each of these, we're doing okay on time. I'll kick it to Lindsay to talk through kind of the patient navigation piece, the texting.
Yeah, so one of the things that we were talking about here was during the pandemic, so something outside of the telehealth realm, but pretty analogous, is how Centers for Independent Living, which are organizations run by and for disabled people who do service provision, have been using text and chat and text a lot, even prior to the pandemic, but we've really seen it take off a lot more since the pandemic began, for information and referral, and then even some service provision as well. I think CILs were possibly a bit ahead of some other social service agencies in this because of the population that they serve and also being disability-led organizations. But the use of text for both information and referral and is kind of analogous to the patient navigation that we could see text being used for in, in the healthcare system. So I think that there's, a lot of opportunities for this to expand. And the fact that we're kind of seeing it done provides us with a model for how this can be done. And I think that there's opportunities also for, not using the kind of the HIPAA sensitive information necessarily either, by putting, some information up there that you don't necessarily have to, it's not necessarily PHI either. So yeah, we were talking through some of the ways that it's already being done in like other industries. And that was one of the models that we thought could be replicated fairly easily. I don't know if you want to talk about the chat that you're doing.
Yeah. So I think chat and chatbot. So I'm a primary care clinician, do a lot of text-based management of patients. So that semi-synchronous piece, one, it just really, like I mentioned before, opens up access for the patient, and team-based care. So I'm an internal medicine physician. I work with a nurse practitioner, and we also have a nurse on our team. So that team-based care piece really opens up just kind of the speed at which we can respond to patient questions and concerns, both medical and even just kind of that navigation piece that Lindsay was talking about. And virtual triage is another way that we kind of can say, do you really need to come in? Or the phrase I generally use is in the same way that we ask, could this meeting have been an email? Could this, could the visit that you need, can we actually just take care of it right here and now? And Lindsay, I'll let you talk about some of the potential for peer group support.
Oh, this muting and unmuting thing. So one of the other things that we've seen, and I was going to say we've seen this in CILS, but we've also seen it in other spaces too. Sorry, CILS or Centers for Independent Living. So we also saw CILS who typically had in-person support groups transition rapidly to holding those groups virtually. So this allowed those groups, which are a core service of Centers for Independent Living. So every Center for Independent Living offers peer support in the form of both usually individual and then group support to continue those through all phases of the pandemic. And a lot of them are talking about how they've been able to reach a whole new group of people who typically couldn't come in to the physical location, especially the centers that are in rural locations or that are serving folks who live in rural locations. And so it's been really successful, and they've been able to reach a whole lot more people through this method. And so I think that this is similar to when you're seeing kind of meetups that we're meeting in person, or in-person support groups that started meeting through like Facebook Meet, or there's a whole bunch of other things like that. But I think I don't want to only refer to the CILS since that's my network, but I do think that provides a good model as well.
Yeah. And then the other half of that, so how do you get patients and clients together? The other half is how do you get busy docs together? And granted, our time is like a little bit tougher, but it's been proven out multiple times, right? Virtual tumor board, virtual transplant conference, and then like long COVID clinics. I've seen these be really, really interesting, where they have multidisciplinary clinicians kind of come together, so the patient's not pinging through over the course of like 4 weeks to try to find 4 different doctors. You just bring all of them together at once, and they commit to that time. So I think the multimodal, multidisciplinary care that we can provide has been proven out in many other realms, so definitely replicable here as well. I think this is our last slide. Next slide. Cool. And like I said, happy to can definitely deep dive. Both of us could deep dive in any of the prior parts that we were talking about, and looking forward to the discussion. Thanks, Helen.
Of course, I'm muted. I've only been at meetings for like 385 days on Zoom, but whatever it is, just want to say thank you. Actually, could you leave the last slide up if you could, as much as I love your contact info. This is a great slide. So I just want to leave it there because I think it'd be a great way to kick off the discussion. And Will, please feel free to join us in this. I think what's really interesting about this slide is it does offer, I like this concept of sort of the multimodal approach to it. It's multimodal and multidisciplinary, I think was the point that you were making, Matt. So maybe for all three of you, so you think about these kind of different models as we think about integrated care. I could see how all of those integrate nicely, potentially, into our usual models of care. Any thoughts specifically as you look at these models with reference to folks with chronic pain and or opioid use disorder or substance use disorder?
Well, I'll make some comments. I mean, from my perspective, from a payer perspective, these models and having a multitude of models, it helps is to create more points of access of care. So someone may come in through the navigation portal, but may be able to be connected then to a group therapy or peer support. So the more access you have, points you have, the better chance to engage and maintain patients in care, in treatment.
That's a great point. Well, I think you're right. The more entry points, the higher likelihood you find a modality that works for them, which they can access. Great point. Lindsay, please.
I'm sorry, I'm so bad with technology. Now I have to lower my hand.
Great, better than me. I was on mute. Goodness gracious, please.
Yeah, so I think when Matt and I were talking about kind of the group visits, I think that's really interesting. I think from my personal experience, I have Ehlers-Danlos syndrome, which isn't super relevant, but it's a condition that affects kind of multiple systems within my body. And so my providers work together. Some of my providers work together. And when the pandemic hit, they started kind of coming up with ways to do that virtually, because previously I was meeting with some of them together. And so being able to communicate with, to have team visits virtually wasn't something that we were able to do, but we figured out ways to communicate online together. And then, they allowed me to start doing self-assessments at home and send the results, so that I needed minor medication changes and minimize the amount of times I had to come into the office. And they started communicating and sending results to each other on things. And so I think they were starting to figure out some of the maybe like telehealth 1.5, we'll say, but I think that putting a lot of these things in place, most of it is focused on managing the pain in different systems of my body together, because I don't just see one pain management doctor. Because if I, have GI pain, for instance, that's not going to be managed in the same way that like my neurological pain is, or things like that. And so I think the group communication, and then also like merging the systems that they're using, because they're not all within the same hospital system either, figuring out kind of how to put these systems together. And then also Matt and I were talking a lot about the asynchronous communication. I think that's going to be a key piece of putting this in play, because sometimes it's as simple as like, hey, I have a question, is this urgent or not? Or like, hey, do I need an appointment, or is this something that we could manage through a phone call? Do I need to come in? So for especially, established patients, when they know me, when they know that I'm, can report what's going on in my body, when I know I've been dealing with this condition my whole life. I think just like putting systems in place to be able to communicate between me and all of my doctors, and for them to be able to communicate together is going to be really important. And I haven't seen that very well when the doctors are in different systems.
Yeah, Helen, I can actually touch on one bit that you're talking, the last question, and the question that's on the screen from Kelly. And it goes back to that. It goes back to that asynchronous piece. So the first part, how do these principles apply specifically for kind of the SUD and chronic pain groups? I think it's that one of the phrases I use is time makes up for touch. So we can't physically be in the same room as a patient, but it's these multiple time points. So particularly with this semi-synchronous chat, where that's, I think, one, again, it just increases access, and you can actually still build kind of that therapeutic relationship through these multiple small touches rather than, one big hour-long visit or 30-minute visit. And specifically to Kelly's point, I can kind of briefly summarize. So basically, and to Lindsay's point, it's fragmented care, right? So you're not all within the same system. How do you kind of get that together? So rather than having everybody on a video, it doesn't always have to be video, it's mostly the exchange of information. One way that you can kind of do this, again, so using Epic as an example, I'm based in San Francisco, I'm at Sutter, UCSF is kind of nearby, Stanford's nearby, but everyone's on Sutter. You can kind of have a group chat in the same way you have like a group text chain with multiple specialists, right? So that's one way to start to get that flow of information that's not, okay, everybody meet for 1 hour synchronously on video to talk through different things. So as a brief way to kind of address some of the things that Kelly is mentioning. Again, I haven't seen anybody pull it off really well, but like from a technical feasibility standpoint, definitely doable.
It's harder when there's a whole lot of specialists potentially involved, if somebody's got multiple chronic illnesses, et cetera. Liz also had an interesting question about, with these SMS alerts, though, how do patients know that they're like the real thing and not more junk that they get in their text box? I feel like I get more and more junk in my text than I ever did lately.
I could take a quick stab at that one. The main thing is kind of like figuring out where your signal to noise ratios are. So like right now, like email is a complete mess in my life, right? So if someone wants to email me something, I'm not going to get through. Text used to be kind of like, if you really need to get through to somebody, that's the place to go. So I think it's actually on the health systems and kind of on the people that are sending them out to judiciously use it. Like don't use text messaging to send the, 2 week prior, 1 week prior, and 1 hour prior reminder for your visit, right? It's like, when do you use it? I think thinking when to use each of these tools, because it's a combination. So I think it's actually very much more on like kind of the designers. This goes back to the co-design idea. How do patients want to get notified? And let's not spam their text.
Yeah, that's really interesting. So Will, a question for you is we've heard a lot about what you've been doing, and then this discussion from Lindsay and Matt. What do you think the role of payers are in particular of trying to forge this forward? We realize we can't do it alone. We've got to have a really different entities kind of engaged from the outset. What's the role of payers, and who else needs to be at the table to make some real lasting change in this area? I think you're on mute now, Will.
Helen, as a psychiatrist, I hate to say I was talking to myself, but anyway, let me mention that, everyone needs to be at the table. It is everyone's problem. So I think that everyone in this call, all these different stakeholders have to be engaged. Our role as payers is just to enable providers to provide good care, to deliver good care, and to enable technology and relationships that are value-based. I think that many of the relationships that we have currently and the ones that we're working on is based on good outcomes for our customers. And I think that at the end of the day, we all want the same thing. We want our patients to be successful in recovery, both from substance abuse and also from chronic pain management. So yeah, I think that our role, actually there's one more piece that I may want to mention. One of our roles too, when we have a partner, is to be able to share information, especially if we need to identify customers that need help. We need to have a way to communicate both ways, because we have a wealth of claims information, pharmacy information, that sometimes the provider is not aware of patients going to multiple pharmacies getting prescriptions or things like that. So we have a number of ways that we can contribute and come to the table.
Yeah, it's great. You mentioned value-based models. I guess one other question for all three of you would be, what about payment reform or alternative payment models could actually potentially incentivize some of these changes that we're talking about today for OUD and chronic pain?
For me, the biggest thing is the fee-for-service bit. I mean, I think trying to generate billable video visits is the best way for this to not work out well. It's mostly what's the overall goal? Try to keep the patient out of emergency rooms using higher levels of care. And then so for me, like I said, all of my patients are actually HMO patients, and so my goal is to not have my in-person clinic day be full. It's how can we handle this? One, so I get to stay home, but two, also you get to stay home on the patient end. So I think since I'm zero RVU based, I'm not looking at how many visits am I doing. That completely changes just my mindset and outset to approach the patient care.
What do you think from the patient perspective? I guess you have multiple hats, Lindsay, but maybe just wearing your patient hat for the moment. What do you think perspectives are on being told, for example, you're virtual first, or a chatbot will communicate with you? Are there concerns about getting to in-person care when you need it, or how can we frame this?
Yeah, I mean, I think yes, because I think the current system is not accessible. And I'm coming from, the disability community in particular. We know that there's barriers that exist. So when you're told, it's virtual first and there's no exception to that, we know that there's just going to be some people who either don't get care or whose care is significantly delayed because of that. And so I think that, we actually had heard at one point that that was being pushed in a potential bill, and we were gearing up to fight that because there need to be exceptions in that type of policy. So I think that, knowing that that telehealth is more available and more accessible, and that's a general policy, that telehealth is going to be available, that telehealth first is the general policy, is, I think, probably a good standard. But I think that knowing not all patients are going to be able to, not all patients are going to have access to that for a number of reasons, and not just disability. And that's not an equitable policy across the board at this moment in time. Has to be taken into consideration too.
Yeah. So, from a payer perspective, I agree with Matt's comments. It has to be a patient's choice. And the way we look at it is that, yes, virtual first, or as an option. And then we incentivize it. You know, if you can go first to virtual, you have a lower copay, but you can go to your brick and mortar and, you know, pay a different copay or co-insurance. So we can set it up so they have that option and we incentivize it, but we want the patient at the end of the day to make the choice.
Great. Lindsay?
Yeah, I do agree to some extent, but I also think that's hard because I think that some of the people who face barriers to telehealth also face, you know, financial barriers. Like some of the barriers are not just disability related, but might be that like they don't have a device for telehealth or they don't have a reliable internet connection, and that could be because of a financial reason. So if they're not wanting telehealth because of that, and then they're going to be stuck with the higher fee for going in person on top of potentially a transportation cost to get to, you know, that's hard also. So
yes.
Yeah, so it's hard because
there's not a perfect solution. We just have to start somewhere.
Right, sure. It just has to be a well thought out. Yeah, yes. There's not a great solution at this point.
Yeah,
and Lindsay, I really appreciate you, and a couple of people mentioned as well in the chat how important it was for you to specifically call out the disability community, which I don't think gets brought up in a lot of these conversations. And I think, you know, the reality is a lot of these systems are really going to suit people's needs differently, but I think people want the ability to get the right care where they need it, when they need it. And so at times that may be in person, and at times we can rely on some of these other methodologies. So yeah, I think that really makes sense. If you could think about, you know, what are the, you all sort of talked, you know, in some ways about what the policy landscape is. I think, Will, you specifically raised the issue of regulatory consistency or inconsistency as being a real problem here. What do you think we could collectively do? That was really one of our goals of putting this session, you know, these suite of seminars together around OUD and pain and telehealth, was really fairly quickly was with the idea that we want to influence the broader policy agenda. What do you think the current policy opportunities are that you think our work group and the NAM could potentially be pushing towards at the state and or federal level? If you start, Bill, please. Go ahead.
From my perspective, I mean, from everyone's perspective, I mean, we need to lobby for some of these changes to happen. And actually, Cigna has a government affairs team that we promote some of the different things that we're talking about here, about, you know, like policy changes of, for example, continuing some of the exceptions that were put in place during the emergency period, and also relating to reimbursement, and having some national standards for telehealth and virtual care, so we don't have to deal with these different regulatory barriers that, you know, to some extent are protectionist. So because, you know, providers don't want providers from different states coming to your state to virtual. So we need to think about, you know, we have a shortage of providers. There's a lot of providers that want to provide virtual, and we need to facilitate access for our patients.
Yeah. How about you, Matt?
Yeah, I think the needing to have that first like face-to-face visit is like a pretty big barrier. So I think and you know, they waived that during the public health emergency. Yep. I think continuing that one, potentially even over the cross-state licensure, that was a huge one. I talk about that one all the time. That eliminating that need for that initial in-person face-to-face will open access, I think, pretty considerably, particularly I think in the, you know, SUD and chronic pain community.
And I think the updated federal rules say you don't need that first visit, at least for mental health. I would just be worried.
For mental health, yeah.
Chronic pain may not be part of that thought. Lindsay, anything from your perspective of where you sit in the pain community?
Yeah, I mean, I definitely think the e-prescribing flexibilities like that is huge. So, and I really think that all of the flexibilities that, you know, have been allowed during the PHE have increased access, which is huge, you know. So I know that a lot of those during the unwinding have really already, you know, even though the PHE hasn't ended, we've seen states start to change their policies. And so we're already starting to see people losing access. So I think kind of all the policies that we've been talking about today have been beneficial for everybody, and that includes people with pain and SUD. And I think Will alluded to this too. I think like having some type of more permanently legislated like standardized national telehealth framework of some sort, which is like a pie in the sky wish, I feel like.
Yes.
But having something like that, I feel like would put us in a much better place. So I'm not holding my breath for that, but I do agree that I do agree that, you know, pushing for more kind of federal guidance around this would, would be.
And I don't think it's a pipe dream. I mean, it's part of the reason we're doing this through the National Academy of Medicine, to be honest.
Right, exactly.
Like there's a little bit of heft there to help push something through. Sorry, Will, I didn't mean to interrupt you.
No, that, you know, one of the things that I would recommend for this organization is to align with some other groups. Like we are partnering with the American Telemedicine Association and the Alliance for Connected Care, so we can have a joint effort to lobby toward getting to those goals. So, you know, there may be something that this group could also look and join other organizations.
Yeah, the National Medicine doesn't lobby, so that's not as much of what their role would be. But I think what we're trying to do is surface what are all the important policy issues where we think there might be solutions on various levels, whether they're clinical or payment or whatever the case may be. I guess I just want to invite the audience to feel free to throw in some questions for this group as well. I guess maybe back to you, Lindsay, maybe specifically from the pain management side, if you could sort of think about what you think would really make a hybrid telehealth sort of in-person virtual hybrid world work best for patients with chronic pain, what would be your ideal state?
Yeah, I mean, I think honestly, a little bit of what, you know, Matt and I kind of talked about in the presentation. I think that right now, the way that prior to the pandemic, everything for me and a majority of the folks with pain and substance use disorders that I knew, at least, pretty much everything was in person, you know. And for me, you know, I was working remotely prior to the pandemic because of my chronic health issues. You know, for me, it's much easier to be able to work at home. I have real fluctuating health issues, and, you know, including my pain. And so sometimes it was really hard for me to get to the doctor's office, but I had to because that was just the way healthcare worked. And so with the pandemic opening up telehealth, that made things a whole lot easier for a lot of us. But there's still certain things that I'm required to go into the office for. And I don't think that's going to necessarily change. Sometimes, you know, I'm not on long-term opioids, and so I'm not, you know, required to go in for drug testing or things like that. But I know that, you know, patients who are will have to go in for that. I do think that there's the opportunity for folks who do need to get like UDTs to have more coordination among specialists, so that they don't need to go in specifically for those, so that when they have other in-person appointments, you know, with a primary care physician or with someone else, they can kind of tack that on. So I think, you know, broader coordination that we've talked about could be beneficial. And I think just broadly, as these systems build out, the main thing is just kind of making sure that both people with pain and people with substance use disorders are a part of building out these systems and the way that care is delivered. I think that's just kind of the main thing, because I'm, you know, one patient who has a lot of privilege in the whole scope of things, and I'm not facing a lot of the barriers that we're talking about when we're talking about these groups of people. So I think that that's kind of the main thing is, as we're talking about the development of these systems, like Matt said, making sure it's not just like an advisory board here or there, but that people are kind of integral in the development of these systems.
Great. Matt, please.
Yeah, no, I love all of those thoughts and insights as well. I think the other piece, particularly for what does that hybrid part look like, is getting current clinicians. It's that therapeutic relationship and trust part. So like the patient reported measures. So kind of to Lindsay's point, like if you needed urine drug testing, we always joke that like now patient self-reported blood pressure and weight may or may not be close to what they want it to be rather than what it is. I think building so RPM bits, I think are helpful. You kind of either remote therapeutic monitoring, remote patient monitoring, I think can help bridge some of that hybrid piece. And I know there are, for me, I'm a pretty trusting guy, but I think a lot of other clinicians kind of have that, are the patient reported measures as good as what we get in the office? So I think bridging that trust gap improving that therapeutic relationship. And again, I think some of these device auto upload things can help start to build some of that.
Yeah, and we heard from some of those companies earlier, being able to track your patient-reported outcomes, have that information shared. I still think there are some concerns about when that all comes to the primary care doc, how do they sort of handle all these data? At some point, Bob Wachter at UCSF said if all the data people are envisioning coming through remote patient monitoring went to his primary care physicians at UCSF, he would, half of his primary care docs would resign immediately, like just the tsunami of information coming at us. So I think that's why there also has to be the ability to have that information come and then kind of pull out the key information as opposed to the information overload. That I think we want to be careful that we don't sort of push, and not just to clinicians, I think to patients as well. I mean, Will, I love the idea of being able to see all those data that health plans have on these patients, but being able to have it in a way that we could actually cull out the information rather than saying, hey, your patient's been seen here and here and here and here and here and here. And it's just, how you get your arms around that can be pretty hard on primary care doc. So same question for you, Will, I guess, if you could think about what would be your top recommendations from a policy perspective, payment perspective, clinical perspective, technology perspectives that would help us push towards this more ideal state for this hybrid care system, particularly for OUD and pain management, but broadly as well. We'd love your thoughts.
How much time I have?
How fast can you do?
Well, I think that we have touched on some of the main highlights of some of those goals. Definitely partnering with the right groups. And, it's something that in behavioral health, especially when we talk about substance abuse treatment, that we have lagged behind is value-based relationships. We have done that in the medical field for years. And it is just now that we're starting to develop metrics to measure good outcomes and finding partners that are willing to work with us on different type of relationship that will be value-based. So I think that expanding on value-based and providing good incentive for our providers to engage with payers that are looking after our patients, it will go a long ways. Also, reimbursement. We have to maintain parity of reimbursement, at least for now, until things are more stable. And another challenge when we move out due to COVID to virtual, for many providers, they lost some of their ancillary income from other services, like from labs, radiology. So as payers, we have to help provider groups find alternative ways to supplement that through virtual services or from other relationships. So there's a number of things that could help drive innovation and hybrid models. And as we talked about regulatory inconsistency, I think that's a big barrier, just having a common language for all of us to communicate and the sharing of information. And again, we are already doing that at Cigna and Evernorth with contracted providers and virtual providers where we help them with predictive models, and actually we help them digest the data, like you were commenting, identify the right patients to go after for better outcomes. So yeah, and we mentioned before, it takes everybody. So we're willing to come to the table and partner with our stakeholders.
It's great. There's some wonderful comments in the chat box if you guys have been reading, including a comment that the VA actually does use their nurse care managers to manage all that RPM data and only engage other clinicians when action is needed, which is great to hear. And then Mary Greeley, who's a member of our pain management work group, pointed out, who leads the Healthcare Leadership Council, that we need to, there's some important recommendations, I think, specifically around CBO scoring and not scoring the extension of waivers as a large cost. And that's an issue I know MedPAC's brought up as well today. I think she's right. We've heard many examples of better outcomes and reduced costs, and we need to communicate that to Congress. Even if NAM can't lobby, certainly the members of the collaborative can work with their national organizations to help bring that voice forward. And really these real world examples we've heard today about what's possible with remote care. And, if one patient avoids going to the emergency department in pain or avoids an overdose, then those are costs we've got to be able to really think about. And Matt, you specifically mentioned the regional telehealth centers. Anything you want to add there as well?
No, I think they're just like a wealth of knowledge because they have, deep like on the ground experience, but they do spend a lot of time kind of having that like forest for the trees view as well. So I'd like recommend kind of as we kind of think through again who's doing it well, they're very good, and each kind of region of the U.S. has a telehealth resource center kind of assigned to it.
That's great. And I do think a key theme of this discussion, and thank you for that comment as well, is we need to share any of the data or even the anecdotes. You know, the line in DC is the plural of anecdote is data, that I think even just getting some of these good patient stories would be powerful as we try to make the case to continue what we've got. So I'm going to turn to my co-chair Kelly for a question.
Thanks. So my question goes back to the sort of constant refrain about value-based care. And, you know, we save a person from going to the emergency room, that's worth something. But in my experience as a payer, as a provider across the board, the data on utilization live in different silos. Behavioral health data lives in one silo, the medical health data lives in another silo, the pharmacy benefit manager data lives in another silo, and et cetera, and et cetera. And it's hard to get at a single patient level what their actual, that individual patient cost of care is all in through all of their providers, and then much less the attribution issue. So I'm wondering if the panelists could kind of talk about the challenges they've seen with that and some of the ways around that they have seen or used themselves.
Yeah. So from a payer perspective, actually Cigna and Evernorth for many, many years, we have integrated model of care. So 95% of our customers have all medical, behavioral health, and pharmacy benefits. And so we are able to integrate and kind of side by side see their utilization and get down to the total medical cost impact on different services. So I agree with you, Kelly. I mean, that's very difficult sometimes to do, but we have a lot of expertise doing that, and we have been successful creating predictive models based on that data to help the most vulnerable patients.
I can speak to it briefly from my end. Like I said, I take only HMO patients, but it's HMOs across all the different ones. So Cigna HMO, Aetna HMO, Sutter has their own product. So the attribution piece is theoretically, I'm kind of the point person as from primary care, but pulling our data together is like a bunch of different Excel spreadsheets that kind of get meshed into one. So that data pipeline is not great as it stands, but that's kind of how we do it, is, you know, with the assumption that if I'm the named primary care physician on the HMO, like attribution goes to me, and then we manage costs from there. But it's not easy to get at the data for sure.
For sure. Yeah, there's a question specifically, this might be for you, Will, about are most payers applying exclusivity to their value-based care relationships, and whether that could become a barrier to care when patients find others in the network through consumer first entry points. Any actual reflections from any of you?
So can we define exclusivity? I'm not sure what are they getting at with that term. Like a closed network, is that what we're talking about? I don't know if
I'm assuming so. Lisa, feel free to chime in to make sure we're interpreting your question correctly.
We can't hear Lisa. I'm going to guess that what she's saying is you put up one TBOT provider already that you have a value-based arrangement with. Are you open to contracting with all the TBOT folks for value-based relationships, or are you just being sort of exclusive across the board with one or two pilot partners?
Yeah, and she put in the chat that she's referring to referral pathways.
Yeah. Okay, referral pathways. So, you know, every payer is different in the relationship. We don't restrict our patients from a specific pathway, and we have multiple relationships with different high-performing providers throughout the nation. So again, going back to what I mentioned before, one of our focuses is increasing access of care. We try not to limit it, except keep in mind that we manage the benefits. So many times there may be some plans that are more restricted, but that's based on the employer's preference. So we have some limitations there.
Ellen, you're muted.
Yep. Matt, any reflections on that question as well?
No particular ones. I mean, I do notice it on my end, again, mostly HMO patients. So there is that level of restriction. I mean, I'm not sure if we'll ever get to a place where there can be almost like prior auth. In the same way you get prior auth for a med, you can like have access to other providers. I guess if you have to provide extra reason for it. It's tough though, but I guess from my end, it's kind of you know the answer and then there's certain guardrails around it. I'm not sure if there's a good way to, break that at the moment currently though.
Yeah, no, it's a good point. I think that's, points out the importance here of working together and kind of figuring out, even the question about what do all these terms mean? I almost feel like you need a glossary in this space. What is inclusivity? What is virtual first? To make sure, I think that all the different players, including patients and clinicians and payers and purchasers, are even using those terms in the same way. Might be a useful output from this convening, if nothing else.
Actually, Helen, there's one piece I'm reflecting back on this now in another life, because I've worked at a couple of other places. Patients with the high deductibles have actually been very interesting, because at that point they're paying cash, so they kind of will look at what's the cash price of going to a virtual only provider and things like that. So I think the level of patient or price shopping that patients are doing now is significantly higher than I've seen even 2 years ago. So I think some of those kind of interesting ways that insurances are going can change it a little bit, especially with these direct to consumer plays.
That's interesting.
Yeah. I think I can get, if I could go back to Lisa's question, I think I get into her point. Most payers do try to steer customers to in-network providers. Okay, so that's standard. I mean, we because the relationship we have with high-performing providers. So yes, we steer, but we do not push patients into a provider. I mean, unless they don't have out-of-network benefits because of design, like I mentioned before, they have the option to go to any provider. But we do try to educate them about the cost advantages and the high-performing providers. So we do that. I hope that helps, Lisa.
Yes, thank you. That's a great answer.
Great. All right, we are at time. What a great discussion. I just want to thank Will and Matt and Lindsay for a really fascinating discussion. Invite my co-chair Kelly back up to the screen here. Where is she? Where is she? And we're just going to sort of wrap up, I think, before we move up. She's back. Excellent. Before we wrap up for the day. So just first of all, just thanks for these amazing presentations. I learned a lot today. And I think you've given us lots to think about, and we're thinking in our next discussion, in our next session, which we'll talk about in a moment, we're thinking about doing sort of more of a summative exercise of what we've learned over the 3 sessions, from the first 3 sessions, because I think there's been so much rich conversation. It's almost difficult at this point to sort of to really summarize where we've been and figure out where we're going, I think, without a chance to think a bit retrospectively. And, from where I sit, love to hear your thoughts. Kelly, I thought there were some really interesting innovations we'd heard about today. I think expanding our vision of what's possible when you think beyond virtual is only virtual and in-person is only in-person, but really thinking about a new model of care that allows you to cross that and not, always be stuck in one model versus another. Lots of interesting multimodal, multidisciplinary approaches. But still, regardless of what the solutions are, we're still faced with remarkable levels of regulatory inconsistency. And I think some hesitancy on moving forward without knowing some assurances about what's going to happen on both the federal and the state policy front. What are your reflections, Kelly?
I think that's very well summarized, Helen. And I would say, I think that this has been the most interactive of our 3 sessions so far, in terms of the number of people, the number of comments in the chat, the interactivity of the chat, the number of people and interactivity of people, speaking and asking questions. And so I'd just like to thank everyone who's still hanging out with us at the 4-hour mark on this, which is 33 people, and remarkable. And our next and final session is we're aiming for June for this. And as Helen said, we're looking to wrap this up with some summaries and where do we go next, and maybe some more chance for interactions and exchange, because you're doing exactly what we've asked you to do, which is to give us the information that we need to summarize here and put forward. So, well, thank you very much on that. And
we'll go ask Aisha to take us home.
Great. Thank you all so much. Thank you to our planning group, to Helen and Kelly for moving us through today, the rest of our moderators, all of our speakers. We're just really grateful for the conversations that we've been able to have today, and looking forward to building on this in the last meeting. I believe we have our meeting link in the chat, so please do reference that. It should already have the materials from the previous meetings uploaded there, and we'll be sure to take everything from today as well and take that up to the website. We'll have discussion proceedings that will highlight areas for action as forthcoming pieces, and also more information about the June meeting that will be forthcoming. So please do stay in touch. Thank you again for joining us, and we'll go ahead and wrap up and give you all 7 minutes back in your day. Thanks so much, everyone. Take care.
Thanks, everybody, for a great session. Bye-bye.